2. 1. Disclaimer: I do not own the rights to the images or information provided. This was strictly made for the purpose of studying for boards. Since the only images are in the cases, I will play some videos that don't directly relate to case examples in the interest of time. Neurologic examination. In this chapter, the term large animal refers to the horse, ox, sheep, goat, pig, and camelody. The neurologic examination of large animals is similar to that of small animals, with adjustments that are necessary to accommodate the size of the patient. 5 components of the examination include: 1. Gait and posture, 2. Postural reactions, 3. Spinal nerves, 4. Cranial nerves, and 5. Sensorium. See Chapter 21 for a description of the complete examination. Only specific components that relate to spinal cord disease are reviewed here. Gait and posture: observe the standing animal for the position of its head, neck, trunk, and limbs, being especially observant for a head tilt, lowered position of the neck, trembling, and tail position. Evaluate the gait on a surface that is not slippery. Walking the patient on macadam or concrete not only makes the evaluation difficult, but it is also dangerous for a paralytic and ataxic patient. Most deficits may be observed at a slow straight walk and on turns as you observe the patient from one side. Subtle deficits may require walking the patient over a low obstacle such as a curb or walking on a slope, if available. Occasionally, trotting the patient is helpful. Turning the patient loose in a paddock may also be useful to observe the patient when it changes the speed of its gait and adjusts to making sudden turns. We rely almost entirely on observing the walking gait from one side as the patient is being led by an assistant, and then we repeat this part of the examination while leading the patient ourselves. Note any delay in the onset of protraction, the swing phase, the ability to support weight, length of the strides, the tendency to overreach with the limb extended, scuffing of the digit or digits, swinging the limb outward, abduction or inward, adduction, swaying of the trunk and pelvis, and the range of neck movements. Spasticity may make the limbs appear stiff and cause the hoof to strike the ground surface abruptly, causing an audible slapping noise on a hard surface. Be aware of breed differences in their normal gait. For example, do not confuse the neurologic sign of overreaching in the thoracic limbs with the normal high action of the Paso Fino and Tennessee walking horse breeds. Postural reactions: the postural reactions as described for small animals may be performed on small pigs, calves, foals, most goats and sheep, cryas, and some adult camelody. The hopping, hammer walking, and hoof replacement tests are the most reliable. If your patient is cooperative, it is possible to pick up one limb and lean into the patient to force it to hop on the opposite limb. In most adult horses and cattle, this task is difficult to do and to evaluate and is obviously stressful for you to perform. It also may be dangerous in a patient that has neurologic dysfunction. We do not routinely use this test in large patients. For larger patients that are cooperative, the following maneuvers require more neurologic function of the upper motor neuron, and general proprioceptive, GP, systems to be normal and may elicit or exacerbate clinical signs that may not be appreciated while just observing the patient walk in a straight line. These maneuvers include head elevation and circling and swaying of the patient. Head elevation: after walking your patient with its head in its normal posture, lift the patient's head with the shank or just by the halter until you have the head elevated as far as possible and your patient is still willing to walk. As you continue walking your patient, this exercise may elicit or exacerbate the tendency of the patient to overreach or float with the thoracic limbs at the end of the protraction phase of the gait. Sometimes, the affected animal will scuff its hoof at the onset of protraction or even buckle onto the dorsal surface of the digit or digits and stumble. Circling: in our opinion, circling your patient 8 to 10 times in each direction is, by far, the most useful manipulation to detect subtle neurologic abnormalities, especially those that affect the and GP systems. Circling: in our opinion, circling your patient 8 to 10 times in each direction is, by far, the most useful manipulation to detect subtle neurologic abnormalities, especially those that affect the and GP systems. This part of the examination should be performed by an attendant as well as yourself. These circles should be fairly small diameter, tight circles, with the person holding the lead located in the center of the circle. Remember that anytime you pull the lead toward you, the pelvic limbs will move away from you. Besides making the patient start to circle, this method is a good way to prevent someone from getting kicked. The normal animal will step around briskly with relatively short strides and will not pivot on a limb or step on itself. All movements will be smooth and regular. A normal patient will act as if it knows exactly where its hooves are located. The patient with spinal cord disease that involves the UMN and GP systems will pivot on the inside limb, which is held in place and not protracted. If the lesion is severe, the patient may collapse or nearly collapse with this maneuver. With mild lesions, an obvious delay will occur in the onset of protraction in the limb or limbs on the inside, concave side, of the circle, creating a pivoting motion on the hoofs. At the same time, the opposite or outside pelvic limb may flex and abduct excessively as it is protracted, which creates a wide swinging motion termed circumduction. The outside thoracic limb may appear stiff and swing across cranial to the supporting inside limb as the patient attempts to circle. The outside thoracic limb may step on the supporting limb. Recall from the previous chapters on the UMN and GP systems that we cannot distinguish between the clinical signs caused by dysfunction of these two systems. See figure 10-2. Because of their close anatomic relationship, these two systems are usually affected together with spinal cord lesions, and differentiating between them is unnecessary. Our objective is to recognize a deficit of the UMN and GP systems together and determine the level of the spinal cord where these systems are affected. Swaying the standing or walking patient that can be easily pulled by the tail to either side or is easily pushed to either side is suggestive of paresis. This test is best performed with the patient walking while you pull the tail toward you. This test may also accentuate an ataxia that accompanies the paresis because the patient may stumble as it adjusts to the change in posture on being pulled to one side. Some variation exists in how much a horse will resist this effort, which makes your interpretation quite subjective. This effort to determine paresis may be accomplished more forcefully by vigorously pulling both the tail and the headlet toward you simultaneously. Paresis may also be detected by firmly squeezing the patient along the trunk, causing it to extend its vertebral column. The paretic animal may sink excessively, buckle its digits, or even collapse on the ground. Backing cooperative patients that have spinal cord disease may have difficulty backing up and will appear awkward or very slow to protract a limb. If the deficit is severe, animals will not protract either pelvic limb and may collapse on them. Spinal nerves are evaluated by assessing the patient's muscle tone and size and spinal nerve reflexes. This examination is performed in small pigs, calves, foals, cryas, and most goats and sheep in a similar manner to small animals where you can straddle them and manipulate and palpate their entire limbs and then place them in lateral recumbents or test the patellar and withdrawal reflexes. In the standing large animal, you are limited to examination of muscle size by vision and palpation, evaluating tail and anal tone and the perineal reflex, performing the cutaneous reflexes, and determining nociception from the skin throughout the neck, trunk, limbs, tail, and perineum. Realistically, if the patient can stand and walk, you can assume that its spinal reflex function in the limbs is intact. In the recumbent large animal, you can manipulate the limbs to determine muscle tone, and you can test the patellar and withdrawal reflexes in the non-recumbent limb. Evaluating these factors in the recumbent limbs is very difficult because of all the weight that is placed on them and especially if the patient has been recumbent for any length of time. Muscle atrophy is a clinical sign of lack of nourishment, disuse, or denervation. Denervated muscles atrophy rapidly. Neurogenic atrophy is faster and more complete than disuse atrophy, although these types may be difficult to differentiate in some patients. A good example of neurogenic atrophy is the diffuse atrophy that accompanies equine motor neuron disease, EMND. Horse owners will complain of a rapid loss of weight in their animals despite an excellent appetite. Remember that a loss of any component of the lower motor neuron, LMN, will result in denervation atrophy. These components include the neuronal cell body in the ventral gray horn as in motor neuron disease, the ventral roots, and spinal nerves as in chronic polyneuritis or any part of the nerve in its course to the muscle as in radial nerve injury. Cutaneous reflexes are especially responsive in the horse, in which tapping the skin with the blunt end of closed forceps or the end of a ballpoint pen or other hard object will usually elicit contractions of the skin all along the side of the animal. In the neck, this event is caused by the contraction of the cutaneous colli muscle innervated by the facial nerve. In the trunk, the cutaneous trunci muscle is innervated by the lateral thoracic nerve from the brachial plexus and the C8 and T1 spinal cord segments. The sensory component of these skin reflexes involves the general somatic afferent, GSA, neurons in the nerves that innervate the area of skin that you stimulate and long interneurons within the spinal cord that course to the C8 and T1 spinal cord ventral gray column for the cutaneous troncium to the facial nucleus in the middle of 4. The cutaneous colli. These cutaneous reflexes are readily elicited in most normal horses. Vigorous stimulation may be necessary to obtain the reflex in some farm animals, and occasionally it cannot be elicited in some normal animals. Remember that this same skin stimulation will also elicit activity in the nociceptive pathway to the prosencephalon, and you should limit the degree of stimulus to prevent injury to both the patient as well as yourself. Focal loss of cutaneous sensitivity is unusual because of the large overlap of cutaneous areas. Focal loss of cutaneous nociception is observed in the region of the tail, anus, and perineum in polyneuritis equi or sacrocaudal fractures in cattle from being ridden by other cattle. It is easy to be misled by what you first believe is an area of hypalgesia or even analgesia. Be sure to repeat the stimulus numerous times before considering it a reliable observation. Nociception is very difficult to evaluate in the recumbent large animal. The patient will often fail to respond to the same stimulus to which it would respond if standing. Sometimes, if this factor is especially important in your interpretation of the anatomic diagnosis or establishing a prognosis, careful use of a cattle prod as a stimulus is helpful. Tail, anus, and perineum. The tail, anus, and perineum are readily evaluated by manipulation of the tail, palpation of the anus, and stimulation of the skin of the perineum. Loss of tone in the tail implicates the caudal nerves and caudal spinal cord segments. Loss of tone in the anus implicates the sacral plexus, sacral nerves, and sacral spinal cord segments. The perineal reflex consists of closure of the anus and flexion of the tail after stimulating the skin of the perineum and thus tests both the caudal and sacral nerves in their spinal cord segments. In the standing horse, evaluate these areas with caution. You can stand beside the pelvic limb and slip your hand under the tail, which you can elevate to check for tone and palpate the anus. The anus is very tight in the normal horse and tightens further when palpated. Patellar reflex. The patellar reflex is the only tendon reflex that is reliable in large animals, and it can be elicited only in the recumbent, relaxed patient. The pleximeter may be used in the smaller animals. In the horse and ox, the lateral side of your hand with your digits extended may be used to strike the intermediate patellar ligament. Hold the pelvic limb as relaxed as possible and in partial flexion. This test evaluates the L4 and L5 spinal cord segments, spinal nerve roots, and ventral branches in the femoral nerves. With LMN lesions, this reflex will be decreased or absent. With UMN lesions, it will be normal or exaggerated. Flexor, withdrawal, reflexes. The flexor withdrawal reflexes are usually elicited by compressing the skin of the coronary band region or the bulb of the hoof with forceps. Occasionally, in recumbent large animals, this test may require the use of an electric prod. In the pelvic limb, the flexion that is elicited is a function of the sensory and motor components of the sciatic nerve and the L6, S1, and S2 spinal cord segments, spinal nerve roots, and ventral branches. Flexion of the hip, however, is a function of the femoral nerve and most of the lumbar spinal cord segments, spinal nerve roots, and ventral branches. In the thoracic limb, the flexor reflex involves several specific nerves in the C6 to T2 spinal cord segments, spinal nerve roots, and ventral branches. The afferent neurons that are stimulated will depend on the site of the stimulus. The coronary band or bulb regions of the thoracic limb are innervated by the median and ulnar nerves in the horse and the radial nerve in addition in the other large animals. The flexion of the joints is mediated through the LMNs that are located in all of the nerves derived from the brachial plexus, which includes the radial, axillary, musculocutaneous, median, and ulnar nerves. These reflexes will all be preserved with transverse spinal cord lesions that are cranial to the spinal cord segments involved in the reflex. Remember that the noxious stimulus that is used to elicit these flexor reflexes also tests the nociceptive pathway through the spinal cord and brainstem to the cerebrum. A transverse lesion between the T3 and L3 spinal cord segments will interrupt these nociceptive pathways, resulting in analgesia caudal to a line that is approximately 2 vertebrae caudal to the level of the spinal cord lesion. This same lesion will interrupt the long interneurons involved in the cutaneous truncee reflex that course cranially in the fasciculus proprius. The level where you can first elicit this cutaneous truncee reflex will be the same as the line of analgesia. Cranial nerves. The cranial nerve examination is important for detecting multifocal lesions and for evaluating spinal cord lesions that affect the first 3 thoracic spinal cord segments and cause a sympathetic paralysis, called Horner syndrome, which was described in Chapter 7. With severe lateral funicular lesions in the cervical spinal cord segments, a UMN paralysis of the entire sympathetic innervation will occur on the ipsilateral side of the body including the head. In horses, this UMN paralysis will be apparent by the ipsilateral whole body sweating that will occur. A focal lesion between the T1 and L4 spinal cord segments that destroys the intermediate gray horn will cause a focal area of sweating while the skin is deprived of its sympathetic innervation. Remember that the function of the sympathetic LMN is dependent on its stimulation by its UMN pathway from the brainstem. The only clinical difference between a UMN or LMN sympathetic disruption lesion is the extent of the clinical signs. Laryngeal adduction. Some equine clinicians test one additional reflex, the laryngeal adduction reflex, using the SLAP test. This test requires the integrity of all of the cervical and the cranial thoracic spinal cord segments, the nucleus ambiguous in the medulla, and the vagal and recurrent laryngeal nerves. The test is performed by standing beside the neck of the horse with one hand grasping the larynx. With the other hand, a brisk slap is delivered to the saddle area of the thorax. In the normal animal, this action will elicit a brief closure of the glottis by adduction of the vocal folds, which you will feel with the hand that is grasping the larynx or you can observe with an endoscope. You will feel the larynx move when this adduction occurs. The anatomic pathway involved in this response starts with the stimulation of cutaneous branches of cranial thoracic spinal nerves that synapse on long interneurons in the ipsilateral dorsal gray horn. Most of the axons of these long interneurons cross to the opposite side fasciculus proprius and course cranially to the medulla, where they synapse on general somatic efferent, LMN cell bodies in the nucleus ambiguous that is contralateral to the side that is slapped. The axons of these neuronal cell bodies enter the vagus nerve and course quadrantally to the thorax, where they leave the vagus nerve in the recurrent laryngeal nerve to course cranially to the larynx, where they innervate the intrinsic muscles that function to close the glottis. Depending on this pathway, unilateral cervical spinal cord lesions that involve the lateral funiculus may cause this slap reflex to be absent when tested on the side opposite from the lesion. Bilateral cervical spinal cord lesions may cause a bilateral loss of this reflex. Be aware that many long-necked horses have a left side laryngeal paresis from a neuropathy in the left recurrent laryngeal nerve, which may cause this slap reflex to be absent when performed on the horse's right side. This reflex test requires considerable practice and experience to perform well, which is something that we have not done and therefore do not believe that we can rely on this reflex to identify cervical spinal cord lesions. Neck discomfort. Neck discomfort should be assessed in any patient in which you suspect a cervical spinal cord lesion. As a rule, It is not present in horses with static or dynamic cervical spinal cord compression from stenosis of the vertebral foramina. It is most common in horses that have degenerative joint disease, DJD, of the articular processes at the synovial joints. If the discomfort is severe, you will see a lack of neck motion as the horse turns at the end of a walk or when being circled. The horse will keep its neck rigid as it moves. If you do not observe this result, stand in front of the horse and slowly move its head and neck to each side to determine the range of motion and whether any resistance exists on one or both sides. You may be able to attract the horse to make this movement using a carrot or apple as a stimulus. A horse with cervical discomfort will often move its trunk and limbs away from the direction that you are moving the head and neck. For more vigorous assessment, stand beside the horse and, using the halter, pull the head toward you while you press with the fist of your other hand on the vertebral bodies to apply pressure to the neck as it is flexed. Perform this exercise on both sides. With unilateral degenerative synovial joint lesions, the horse usually exhibits more discomfort when the neck is flexed laterally away from the side where the lesion is located. Summary of clinical signs at specific areas of the spinal cord. The spinal cord is divided into 4 regions based on the clinical signs that are exhibited when any one of these 4 regions are affected. See Figure 10-1, which also applies to these large animals. Lumbosacral, 4th lumbar through the caudal spinal cord segments, normal thoracic limbs, paretic with short strides from decreased ability to support weight to paraplegia, decreased or absent tail, anal, and pelvic limb tone and spinal reflexes, atrophy of pelvic limb muscles, hypalgesia or analgesia of the tail, anus, and pelvic limbs caudal to the cranial border of the lesion, urinary incontinence and obstipation. Thoracolumbar, 3rd thoracic to the 3rd lumbar spinal cord segments, normal thoracic limbs, pelvic limb spastic paresis, paraparesis, and ataxia to spastic paraplegia, normal tail and anal tone and reflexes and normal to increased pelvic limb tone and reflexes, no neurogenic atrophy, hypalgesia or analgesia caudal to the cranial border of the lesion, focal sweating in horses, urinary incontinence. Quadricervical, 6th cervical to the 2nd thoracic spinal cord segments, ataxia and paresis of all 4 limbs, ataxia and tetraparesis, to tetraplegia, pelvic limb spasticity and thoracic limb flaccidity, normal or increased pelvic limb tone and reflexes, decreased to absent thoracic limb tone and reflexes, though, thoracic limb muscle atrophy, hypalgesia to analgesia caudal to the cranial border of the lesion. Hypalgesia may be more pronounced in the thoracic limbs, Horner syndrome plus sweating of the entire side of the body in horses. Craniocervical, 1st cervical to the 5th cervical spinal cord segments, ataxia and spastic paresis of all 4 limbs, ataxia and tetraparesis, to tetraplegia, ataxia and spastic paresis may be more obvious in the pelvic limbs, normal or increased tone and reflexes in all 4 limbs, hypalgesia caudal to the cranial border of the lesion, Horner syndrome and sweating of the entire side of the body in horses. Grading system for horses in an attempt to quantify the neurologic signs for comparative diagnostic purposes, for prognosis, and to follow the course of the disease with or without treatment. Dr. Ian Mayhew developed a grading system for cervical spinal cord disorders in horses, based on the degree of neurologic deficit present in the patient. This system differs from the grading system used in small animals with thoracolumbar lesions, which grades the degree of function present in the patient. In small animals, the degree of spinal cord damage and resultant clinical signs are used for surgical selection, as well as for prognosis and to follow the course of the disorder. Grade 0, normal strength and coordination. Grade 1, normal gait when walking straight, slight deficit on walking in tight circles or walking with the neck and head extended or when pulled by the tail, sway. Grade 2, mild spastic tetraparesis and ataxia at all times and especially during the manipulations described for Grade 1. Grade 3, marked spastic tetraparesis and ataxia with a tendency to buckle and fall on vigorous circling, becking, or swaying. Grade 4, spontaneous stumbling, tripping, and falling. Grade 5, recumbent, unable to stand. Case example 11-1 signalment, 2-year-old male thoroughbred chief complaint, abnormal pelvic limb gait history. 10 days before this examination, the horse suddenly began to sway and stumble in the pelvic limbs, and this dysfunction has progressed slightly since the onset. During these 10 days, the horse received treatment for a presumptive protozoal infection with no effect. Examination, see Video 11-1. The horse exhibits most of the clinical signs that were described for a disorder affecting the UMN and GP systems in the cervical spinal cord. Note the tendency to delay and occasionally buckle at the onset of protraction with the thoracic limbs, as well as overreaching, floating, before the end of protraction. Most owners do not recognize this thoracic limb overreaching and complain only about the pelvic limb gait abnormality. Anatomic diagnosis, focal or diffuse spinal cord lesion between the C1 and C5 segments. Differential diagnosis, vertebral stenosis, equine degenerative myeloencephalopathy, EDM or neuroxanal dystrophy, equine protozoal myelitis, discus spondylitis. External injury and vascular compromise were excluded because of the history of progression of clinical signs and the lack of any circumstance in the environment of this patient that would account for any external injury. Neoplasia is rare in the vertebral canal or spinal cord of horses and especially at this age. We have never seen an extruded or protruded intervertebral disc in a horse of any age, and reports are rare. Be aware that infections with the rabies virus and West Nile virus, WNV, may first produce clinical signs of spinal cord disease. Rabies always progresses very fast, and most horses will develop intracranial signs and be recumbent in approximately 4 days and dead by 10 days. WNV encephalomyelitis progresses at a variable rate from acute, similar to rabies, to a very slow chronic progression or even recovery from mild clinical signs. Cervical vertebral stenosis. Cervical vertebral stenosis is a very common disorder in horses that causes a compressive myelopathy. This condition was described for dogs in Chapter 10 and will be repeated here for the horse. Remember that the primary disease involves the cervical vertebral column. The compressive myelopathy is secondary because the spinal cord is in the way of and compromised by the vertebral stenosis. Figure 11-1. Congenital and acquired forms of this disorder have been found. Congenital occipital malformation. Congenital vertebral malformation is uncommon. An inherited malformation that involves the occipital and cranial cervical somites occurs in the Arabian breed and is termed occipital malformation, OAAM. This condition is presumed to be inherited as an autosomal recessive genetic disorder. In this malformation, the factors that determine the formation of the occipital bone, the atlas, and the axis have been affected such that the atlas is occipitalized and fused by fibrocartilage to the occipital bone. The caudal portion of the atlas, which should consist of articular fovea, has a more rounded appearance similar to occipital condyles. The axis has a more atlas-like appearance and has transverse processes that tend to resemble the wings of the atlas. The malformed axis usually forms a false joint and thickened connective tissue ventral to the fused atlas. This defect involves the development of the sclerotomal portions of the occipital and cranial cervical somites. Clinical signs reflect the compression that occurs to the cervical spinal cord within a reduced foramen in the atlas, or occasionally, the malformation has occurred without spinal cord compression. Foals may be born recumbent and unable to stand if the spinal cord compression is severe at birth. If assisted to stand, they exhibit a severe spastic tetraparesis and ataxia and readily fall, especially if they extend their neck to nurse. Occasionally, an audible click will be heard at the site of the malformation when the head is moved. This sound most likely represents movement at the luxated atlantoaxial joint. Other foals with this malformation may not show clinical signs until a few weeks or months of age. Progression of these signs usually follows. This delay in clinical signs probably reflects the failure of the vertebral foramina of the malformed atlas or axis to remodel to accommodate the enlarging spinal cord. As a rule, the clinical signs of spastic tetraparesis and ataxia are quite profound in all four limbs. An important diagnostic feature is the abnormal neck posture. The head and neck are more extended than normal and have a stiff appearance. Careful palpation will diagnose this abnormality, given that no movement will be noted at the normal position of the atlanto-occipital joint, and the normally palpable broad transverse processes, wings, of the atlas are reduced to small stubs of bone. Figure 11-2. Radiography will reveal the extent of the malformation, and myelography is necessary to diagnose the specific location and degree of spinal cord compression. Figures 11-3 and 11-4. Computed tomography, CT, and three-dimensional reconstructions may be quite useful for understanding these complex bony malformations. Video 11-2 shows a 6-month-old Arabian with this malformation. Note the severe gait disorder, the extended neck posture, and the inability to flex the atlanto-occipital joint. We have seen a variation of this malformation in one half Arabian foal that remained recumbent after birth, in which an attempt was made to develop two atlantes and two axes. One atlas was reduced in size and fused to the occipital bone. The other atlas was somewhat normal in size and shape and articulated cranially with the occipitalized atlas. It articulated caudally with an enlarged axis that had a very long narrow cranial portion in the position of the dens and cranial part of the body. Study of the numerous growth plates indicated the formation of two fused axial bodies. The elongated cranial portion projected into the vertebral canal and compressed the spinal cord. Acquired cervical vertebral stenosis. Acquired cervical vertebral stenosis is most commonly termed the wobbler syndrome. In reality, this term is non-specific and should be avoided because any cervical spinal cord lesion will make a horse wobble. Too many abbreviations have been used to indicate this disorder, and they only cause confusion. Therefore, we will avoid using any of these abbreviations in the following discussion. In our opinion, these acquired cervical vertebral stenoses are the result of malformation, malarticulations, or both, which may be secondary to osteochondrosis, a common developmental bone disorder in rapidly growing young animals such as the horse. This disorder is multifactorial, which has all the features that are so prominent in the racehorse industry. 1. Selecting for the genes that will foster rapid growth. 2. Providing feed that is high in calcium and energy to encourage this rapid growth. And 3. Placing these animals as soon as possible into a vigorous training program to make them winners as 2-year-old horses. Nothing could be worse for these young athletes. Two forms of this vertebral disorder are observed. 1. A vertebral foramen stenosis in the younger horse, and 2. A degenerative disorder of the synovial joints that results in stenosis and is usually in older horses. But the age is quite variable here. Stenosis of one or more vertebral foramina occurs in young horses from approximately 4 to 24 months of age. This abnormality is most common in male thoroughbreds, but any breed and sex may be affected. As a rule, stenosis more commonly affects the middle cervi, cow vertebra from C3 to C6 and is caused by failure of the bone that surrounds the vertebral foramen to resorb sufficiently to enlarge the foramen enough to accommodate the growing spinal cord. Figures 11-5 through 11-8. This stenosis occurs at either end of the vertebral foramen of a vertebra or on both sides of the articulation between two vertebrae. A prominent feature is the dorsal projection of the caudal epiphysis, which narrows the caudal opening of the vertebral foramen. Figure 11-9. One or more vertebrae may be affected in a single horse. This lesion has been produced experimentally in Great Dane puppies fed an unrestricted diet, and it has been prevented in thoroughbred foals by restricting their diet and its calcium and energy content, as well as volume, and restricting the foal's exercise. Two categories of this stenotic lesion have been described, a static form and a dynamic form. Normal functional anatomy and disease often defy strict classification, thus overlap is common here, but consideration of these two categories may help in determining what therapy to consider. Static and dynamic stenoses. Static stenosis is indicated when myelographic evidence is found with significant spinal cord compression on both the normally extended neutral and the flexed radiographic views of the cervical vertebrae. Dynamic stenosis implies instability at one or more articulations and is diagnosed when significant spinal cord compression is visible only on the radiographic view of the myelogram made when the neck is flexed. Several measurements have been described for determining whether a clinically significant stenosis is present in the cervical vertebrae. In many horses, this diagnosis can be made with lateral cervical vertebral radiographs of the standing horse that is lightly sedated with its neck in its normal resting position. Occasionally, the stenosis is very severe and obvious without any measurements. More common are characteristics observed that suggest a stenosis, and these characteristics gain more significance in the presence of measurements that indicate a narrow vertebral canal at some point. The radiographic features that suggest a stenosis include 1. A slight subluxation between vertebrae with increased flexion or dorsal angulation between adjacent vertebrae that is best seen between the bodies on either side of the intervertebral disc. 2. A prominent caudal epiphysis that projects dorsally into the vertebral foramen. 3. A caudal extension of the vertebral arch over the articulation. See figures 11-5 through 11-9. The measurements of the size of the vertebral foramina may be performed and are expressed as a ratio to prevent errors associated with the size of the patient and the distance between the origin of the X-rays and the patient. The minimal sagittal diameter for the vertebral foramen of a vertebra is made by measuring the height of the vertebral foramen at its most narrow point. The minimal sagittal diameter ratio is determined by dividing this measurement of the minimal sagittal diameter of the foramen by the maximal sagittal diameter of the vertebral body, which is at the cranial aspect of the vertebral body. These measurements must be made perpendicular to the ventral surface of the vertebral foramen. A study in 1994 considered a ratio below 0.52 for C4 and C5 and below 0.56 for C6 and C7 to be abnormal. Greater ratio values are considered normal. Unfortunately, the value of these measurements is significantly influenced by the evaluator, which may lead to misdiagnosis. This radiographic study may be sufficient to make the presumptive diagnosis of cervical vertebral stenosis with presumptive compressive myelopathy. See figure 11-5. If the diagnosis is less certain, or if surgical therapy is a consideration, cisternal myelography is required, and the patient must be placed under general anesthesia. Myelography is necessary to distinguish between a static and a dynamic stenosis. When viewing the myelogram, be aware that, in a lateral cervical vertebral radiograph with the neck flexed, the ventral contrast column will always be thinned over the articulations. The lateral cervical vertebral radiographic view with the neck flexed clearly shows the large range of motion that normally occurs between adjacent cervical vertebrae. A rule of thumb that is often used is that most horses with a significant stenosis will exhibit a 50% decrease in the height of the dorsal contrast column at the flexed articulation when compared with the height in the middle of the vertebral foramen. A recent study, which was correlated with an autopsy diagnosis of the lesion and its location, indicated that a 70% decrease was more reliable when the neck was flexed. A more accurate measurement is to compare the total height of the dural tube, from the ventral surface of the ventral contrast column to the dorsal surface of the dorsal contrast column, where it is the smallest at the articulation with the same measurement of the maximal diameter of this tube in the middle of the vertebral foramen. A decrease of 20% or more at the articulation suggests a significant stenosis. In a static stenosis, evidence on a myelogram will show significant stenosis with the neck in its neutral extended position, as well as the flexed position. In a dynamic stenosis, significant stenosis is evident only on the flexed neck view. Spinal cord compression in cases with a dynamic stenosis may be prevented by surgical arthrodesis of the affected cervical vertebrae. In the next few years, magnetic resonance imaging, MRI, will be more readily available for evaluation of the cervical spinal cord of horses. One MRI study showed poor to slight agreement with the location of the histopathologic lesions observed in the spinal cord at autopsy. It is hoped that this will improve with better technology and more experience. Degenerative joint disease, DJD, of the synovial joints at the articular processes is the other form of vertebral stenosis that may result in spinal cord compression. This osteoarthropathy is more common in older horses but has been seen in yearlings. This lesion usually occurs in the more caudal cervical vertebral articulations. We believe that this degeneration is the result of chronic malarticulation at these joints that represents the effects of osteochondrosis when these patients were young or an injury followed by malarticulation. This degeneration was observed in the study of the Great Dane puppies fed an unrestricted diet. Horses that have the stenosis related to these degenerative articular lesions have an increased incidence of osteochondrosis of synovial joints in their limbs. Spinal cord compression occurs when the proliferation of the articular processes and joint capsules extends into the vertebral foramen. Occasionally, a synovial cyst develops associated with the degenerate joint capsule and contributes to the compression. Because of their dorsolateral location, these osteoarthropic lesions may show evidence of spinal cord compression on myelograms taken with the horse's neck extended. If this DJD only occurs on one side, the compression and the clinical signs may be mildly asymmetric. As a rule, when a horse exhibits discomfort on neck movements, this degenerative joint lesion is usually present. Figures 11-10 through 11-16. With either form of this cervical vertebral stenosis, the clinical signs may be sudden in onset and exhibit a variable progression, or the clinical signs may develop and progress slowly over a period of weeks to months. When they develop slowly, owners often believe their horse is lame from an orthopedic disorder. No medical therapy exists for these patients. For many years, surgical arthrodesis of the vertebral bodies has been used especially for the patients with a dynamic stenosis. Arthrodesis has also been performed on horses with DJD to stop the movement at the joints that malarticulate, which provides opportunity for resolution of some of the soft tissue and hard tissue proliferation. Surgery has been most effective for horses with the dynamic stenotic form of this disorder. Most surgeons believe they can improve the clinical signs by at least 1 grade, and numerous mildly affected race horses have gone back to racing. Obviously, the owner needs to be informed of the potential danger associated with riding a horse that may appear to have recovered but may well have permanently lost enough axons at the site of the compers, sign to cause the animal to stumble when in a stressful situation. A normal neurologic examination in no way guarantees a normal spinal cord. It is one thing to surgically repair a large breed dog with this disorder so that it can walk up and down stairs without assistance, but a human life is put in danger when a surgically repaired horse is put back into service. On the racetrack, many human lives are put at risk when one of these operated horses is loaded into the starting gate. The veterinary surgeon, as well as the owner of the patient, must accept the responsibility for the consequences of this risk. This disorder may be prevented by slowing the rate of growth of foals by altering their diet and structuring a less vigorous training program while these horses are young. It may be hard to imagine a racehorse trainer recommending a restricted diet and less vigorous training program. Nonetheless, it will definitely work to reduce the incidence of this disorder. A study was done on large breeding farms in Kentucky, in which the foals were radiographed starting at 3 months of age. Radiographic changes were graded, and horses that were considered to be at risk for developing the cervical vertebral disorder were placed on a restricted diet as well as a restricted exercise program. These management changes resulted in a significant decrease in the incidence of this disorder on these farms. Equine degenerative myeloencephalopathy or equine neuroxinal dystrophy. Equine degenerative myeloencephalopathy, EDM, is a diagnosis that is much less common now than it was 10 to 15 years ago. The two terms used to name this disease are redundant, given that a myeloencephalopathy is a degeneration by strict definition. Nevertheless, we will keep this name to be consistent with the literature. The primary lesion is a diffuse axonopathy throughout the white matter of the spinal cord that predominates in the superficial tracts of the dorsolateral and the ventral funiculi, but all portions are affected with at least lesions in the dorsal funiculi. Figure 11-17. This axonopathy is accompanied by a secondary demyelination and astrogliosis. Figures 11-18 through 11-21. In addition, loss of neuronal cell bodies and spheroid development, neuroxinal dystrophy, NAD, is extensive in the medullary lateral cuneate nuclei, with variable spheroid development in the medullary medial cuneate and gracilic nuclei. The nucleus of the dorsal 37 spinocerebellar tract, nucleus thoracicus, in the spinal cord dorsal gray column, and olivary nuclei, reticular-forma Cheyenne, and vestibular nuclei in the brainstem. Figures 11-22 and 11-23. This brainstem nuclear lesion is the reason for including encephalopathy in the name of this disorder. In addition, an accumulation of lipid pigment occurs in the endothelial cells of capillaries in the spinal cord and the pigment epithelium and outer layers of the retina, similar to older horses with motor neuron disease. These lesions are now thought to be the result of a deficiency in the availability of vitamin E in the diet or a disorder in its metabolism. In addition, some evidence has been found to support a possible familial basis for EDM. On 2 large horse farms, the incidence of this disorder was significantly reduced when the diets of the pregnant mares and their foals were supplemented with vitamin E where serum vitamin E levels have been studied. These have only been reduced in clinically affected horses less than 1 year of age. Foals raised in stables and on dirt paddocks with no access to green feed are at risk for developing this disorder. Young zebras raised in captivity in a similar environment have been diagnosed with this disorder. As a rule, this lesion develops only in young horses. Older horses with vitamin E deficiency develop the XLM and degeneration of equine motor neuron disease, EMND. We believe that the remarkable decrease in this diagnosis of EDM parallels the decrease in the diagnosis of EMND because horse owners are more aware of the need for vitamin E supplementation, especially when a source of green feed is limited. Similar myelopathic lesions occur in nutritional deficiencies in other species of domestic animal. A good example is copper deficiency in small ruminants. Copper levels are normal in the tissues of these affected horses. The onset of clinical signs of EDM NAD in affected horses is reported to vary from birth to 2 years. However, most affected foals are only a few months of age, 6-12 months. When these clinical signs first occur in the pelvic limbs, those horses considered to be first affected after 1 year of age may well have had prior clinical signs that were not recognized. The clinical signs of spastic paraparesis and pelvic limb ataxia slowly progress to the thoracic limbs. If an affected horse is monitored for many months, the progression seems to cease before the affected horse becomes unable to stand. These clinical signs are identical to those caused by the malformation malarticulation disorder. Radiography is required to diagnose the latter. No radiographic abnormalities are noted in the cervical vertebrae of horses with EDM. In a prolonged case of this disorder, a fundic examination may possibly show yellow discoloration if the lipopigment accumulation in the retina has been extensive. Vitamin E supplementation of affected horses will stop the progression of the clinical signs but will not improve them because this condition is an axonopathy, which cannot resolve, nor can these axons be effectively replaced. The disorder may be prevented by supplementation of the pregnant mare in her foal at birth with vitamin E. Equine neuroxynal dystrophy. Equine neuroxynal dystrophy, ENID, has been more recently described in young horses with a similar signalment, history, and clinical signs as those of horses with EDM, which includes being on a diet deficient in vitamin E in these horses. The lesions are limited to neuroxynal dystrophy associated with specific populations of neurons, and no microscopic lesions of axons are present in the white matter of the spinal cord or brainstem. The affected neuronal populations consistently include the medial and lateral cuneate and gracilic nuclei. Numerous breeds are affected usually by 6 to 12 months of age. Affected foals have low serum levels of vitamin E at present. EDM and ENID in young horses are considered two pathologic presentations of vitamin E deficiency that is related to the genetic backgrounds of the affected horses. The reason that a population of these horses has no axonopathy in the spinal cord white matter tracts is currently unknown. The diagnosis of the EDM-ENID complex is only confirmed at autopsy. In young horses with the appropriate signalment, history, and anatomic diagnosis, the presumptive clinical diagnosis is made by finding normal cervical vertebral imaging, negative testing for sarcocystis neurona antibodies, and low serum vitamin E levels. Vitamin E treatment of affected patients is ineffective and these horses will remain unfit for any performance activity. Numerous breeds are affected. Breeding trials in Morgan horses supported a genetic basis in this breed as an autosomal dominant inheritance with a variable expression. Despite the similarity of the clinical signs across many breeds, it remains to be determined if the etiology is shared by all affected horses. This diagnosis is very unlikely for the thoroughbred in this case example because of the sudden onset of clinical signs in a 2-year-old horse. Only the anatomic diagnosis is compatible. Video 11-3 shows a 1-year-old female Arabian horse that has a recognizable gait abnormality that has been slowly progressing for 6 months. Radiographic study of the cervical vertebrae was normal. The horse was euthanized, and EDM was confirmed at autopsy. Equine protozoal myelitis is the most common inflammatory disease of the central nervous system, CNS, of horses, especially the spinal cord. It may occur anywhere in the spinal cord with lesions in white and gray matter. It often has a multifocal distribution. If these inflammatory lesions occurred bilaterally in one cervical spinal cord segment or were randomly scattered through several cervical spinal cord segments so that both sides were affected at some point between the C1 and C5 spinal cord segments, the clinical signs would be compatible with those observed in this case example. This protozoal disease is described in case example 11-2. Discus spondylitis. Discus spondylitis is a disease most commonly observed in foals that have experienced a bacterial infection and have been septic. Although this disease may occur at any level in the vertebral column, the caudal cervical vertebrae appear to be at some risk for this infection. The mass effect of the abscess associated with this infection or the subluxation of the unstable fibrocartilaginous joint causes spinal cord compression. These foals usually hold their neck stiff and exhibit discomfort when the neck is handled. They often have a fever and mate of neutrophilia in their complete blood cell count, CBC. Cerebrospinal fluid, CSF, is usually normal because the infection is external to the dura. The lesion can usually be observed on radiographs. CT and MRI may also be used to make the diagnosis if the foal is small enough. If you use general anesthesia for restraint, be extremely cautious of manipulating the neck of these patients because the involved articulation will be very unstable when muscle tone is absent. This diagnosis would be unlikely in the horse in this case example because of its age and lack of any systemic clinical signs of an infection. Video 11-4 shows Gabriel, a 1-month-old Percheron colt that had become lame at 3 days of age with a swollen tarsus and he had a fever. Suppurative tarsitis was diagnosed, and he improved on antibiotic therapy. 10 days later, the fever returned. He had difficulty standing, and his gait became stiff. Study the video and make your anatomic diagnosis. The anatomic diagnosis was a focal or diffuse spinal cord lesion between the C1 and C5 segments. The radiographs and CT scans, see video, show discus spondylitis at the C6, C7 articulation. The CT images are from the middle of C5 to the middle of C7. Note the subluxation on the CT reconstruction. The foal was unable to stand after this procedure, and the subluxation likely occurred during the CT procedure when the foal was anesthetized. The initial lateral radiographic view of this standing foal was sufficient to make this clinical diagnosis. The clinical signs showed a compressive effect of the infection on the white matter at this site and not the gray matter. This case exemplifies the importance of the supportive role of the unanesthetized muscles in spinal cord injuries as well as the need for care once the patient is anesthetized. Radiographs of the horse in case example 11-1 revealed a stenosis between the C3 and C4 cervical vertebrae and DJD of the synovial joints at the C5, C6 articulation. A myelogram showed spinal cord compression related to the DJD at the C5, C6 articulation. Surgical arthrodesis of the vertebral bodies was performed at this articulation. No follow-up information on the patient is available. See the following videos to appreciate the clinical signs of equine cervical vertebral malformation malarticulation in several horses. After studying these videos, you should feel comfortable in recognizing the anatomic diagnosis of a C1, C5 spinal cord lesion. Video 11-5 shows a 4.5-month-old quarter horse colt that went down suddenly in the paddock 3 weeks before this examination. A gait abnormality was recognized when he was assisted to stand, and this abnormality has progressed slightly since then. The radiographs in the myelogram, see video, show a dynamic stenosis at the C3, C4 and C4, C5 articulations, but especially the latter, where the total dural tube diameter is reduced in size greater than 20% when the neck is flexed. Video 11-6 shows a 1-year-old standard-bred colt with an abnormal gait that was found when he was on pasture. These clinical signs may have been present and not recognized for a few days. He was placed in a stall, and the clinical signs became worse over the week before he was presented for this examination. Radiographs showed abnormal vertebral foramina measurements, indicating stenosis at the C3, C4 and C4, C5 articulations and DJD at the C6, C7 articulation. Myelography was not performed because the owner did not consider surgery as an option. The horse was euthanized, and had autopsy. A compressive myelopathy was found in the spinal cord at the site of the C4, C5 articulation. Video 11-7 shows a 6-year-old Dutch warm blood mare with a gait disorder that progressed very slowly for 6 months. For the first few months, only an orthopedic disorder in the pelvic limbs was considered but could not be diagnosed. Acupuncture, chiropractic adjustments, and corticosteroid injections into the epaxial muscles were all ineffective. On the video, the gait disorder now obviously represents a dysfunction of the UMN and GP systems in the cervical spinal cord. Radiographs, see video, showed DJD at the C5, C6 and C6, C7 articulations. This horse was euthanized, and diagnosis of a compressive myelopathy at the level of the C6, C7 articulation, see figures 11-14 through 11-16, was made at autopsy. Video 11-8 shows a 6-year-old thoroughbred gelding that had fallen on an icy road 10 months before this examination. A gait abnormality was observed approximately 5 months later and had been slowly progressing since that time. Radiographs, see video, showed mild DJD at the C4, C5 articulation and severe degenerative synovial joint lesions at the C5, C6 articulation. The horse was euthanized, and autopsy showed a compressive myelopathy at the level of the C5, C6 articulation. In this horse, the initial fall may have injured these articular processes, which caused malarticulation and the subsequent development of these degenerative vertebral lesions. Case example 11-2 signalment. 14-month-old thoroughbred colt. Twain history. 11 days before this examination, this colt had suddenly become lame in the right thoracic limb, and a shoulder or radial nerve injury was suspected. However, the clinical signs worsened and included abnormal use of the right pelvic limb. Examination. See video 11-9. When this horse was circled to its right, it was felt that he might fall because of lack of normal support in the right thoracic limb. Note the occasional tendency to buckle in the right thoracic limb and the way he flips the digit forward to land on the sole of the hoof. This is different from overreaching with the limb in extension. Anatomic diagnosis. Focal lesion in the right C6 to T2 spinal cord segments to right thoracic limb. Clinical signs were predominantly those of an LMN paresis, but some involvement of the UMN and GP systems cannot be excluded. The actions described previously reflected a partial deficiency of radial nerve function. The right pelvic limb clinical signs were all caused by UMN paresis and GP ataxia. To best appreciate these clinical signs, view the video at least twice. The first time, watch the right thoracic limb gait, and the second time, concentrate on the right pelvic limb gait. Differential diagnosis: equine protozoal myelitis, EPM, cervical vertebral malformation malarticulation, EDM or neuroxonal dystrophy, discus spondylitis external injury, fibrocartilaginous embolic myelopathy, and equine herpes virus. 1 myelopathy were not considered because of the history of progressive clinical signs. Neoplasia was not considered because of the age of this horse and the rarity of this particular diagnosis in the equine CNS. Equine viral myelitis was considered unlikely because of the focal nature of the clinical signs limited to the spinal cord and the duration of clinical signs for rabies and the eastern equine viral encephalitis. EPM is the most presumptive clinical diagnosis for this thoroughbred, primarily because of the asymmetry of the clinical signs that included involvement of the gray matter, LMN. This degree of asymmetry would be very unusual for a malformation malarticulation disorder. Unilateral DJD of a synovial joint may cause a mild asymmetry but not to this degree and not with the LMN clinical signs because of gray matter involvement. Sudden onset, asymmetric signs, and clinical signs of gray matter disease do not occur in EDM or neuroxonal dystrophy. The asymmetry, age, lack of discomfort, and lack of fever would make a discus spondylitis unlikely. Equine protozoal myelitis EPM and equine protozoal encephalitis, EAP, are the most common CNS inflammatory diseases in the horse. Figure 11-24. Approximately 50% of all horses in the United States are infected, according to estimates based on serum antibody assays for what presumably is the most common protozoal agent involved, Sarcocystis neurona. The incidence varies among states, and, in some areas, the incidence increases to 80% in older horses. Antibody levels increase with the age of the horse, suggesting re-exposure to the protozoa or the horse has a chronic persistent infection that continually stimulates the immune system and places this horse at risk for clinical illness. Neospora hussy has also been implicated in a few horses, primarily in the West Coast states. This disease is not contagious, as it cannot be passed directly between horses. The normal life cycle of S. neurona requires a primary host and an intermediate host. The most recent field and laboratory studies implicate the opossum as the most likely primary host. This assumption correlates well with the disease being limited to the Americas, where the opossum is also located. This disease is not seen in European horses that have not traveled to the Americas. Several species of North and South American possums have been identified as definitive hosts. The natural intermediate hosts that have been identified include the raccoon, striped skunk, and nine-banded armadillo. The horse is an aberrant intermediate host in which the life cycle cannot be completed. In the normal life cycle, the S. neurona merozoite that is encysted in the muscle of the intermediate host is ingested by the opossum, where it invades the intestinal epithelium. Sexual reproduction takes place in this epithelium, resulting in the production of oocysts, which enter the intestinal lumen and sporulate to form sporocysts. Each sporocyst forms 4 sporozoites, which pass through feces into the external environment, where they are ingested by the intermediate host. The sporozoite invades the intestinal epithelium and associated arterial endothelial cells of the intermediate host. Asexual reproduction by schizogony takes place in these endothelial cells, resulting in the production of merozoites that are released into the bloodstream and migrate to the muscles where they encysted. When the intermediate host dies, and the muscles are eaten by the opossum, the cycle is completed. The horse becomes infected when it eats feed that has been contaminated by the feces of the opossum that contain infective sporozoites. These sporozoites are presumed to invade the intestinal epithelium, where asexual reproduction occurs, and how the organism reaches the CNS is unknown. Schizogony is seen in the CNS, but whether it also occurs in intestinal or other extraneal vascular endothelium is unknown. Merozoites have occasionally been found in CNS endothelial cells. Cysts have not been reported in the muscles of the horse, but these have not been adequately studied for this possibility. The assumption is that the CNS infection is usually hematogenous, with merozoites circulating free in the bloodstream or in infected lymphocytes. However, some unique cases have been found in which focal motor nuclear lesions in the CNS make a route over nerves that innervate infected muscle a strong possibility. See case example 6-11. Neospora hussey presumably has a similar life cycle involving primary and intermediate hosts that have yet to be identified. All breeds of horses are susceptible to this infection. The few horses that develop lesions are thought to have been subject to some form of stress such as transportation, training, showing, pregnancy, or some other change in their environment that might lead to stress-related immunosuppression. Immunosuppression is thought to be a common factor in protozoan infections. Both humoral and cellular immunity are thought to be involved in the resistance of the horse to the development of lesions. The disease occurs at any age, but it is most common in young adults between 1 and 5 years of age. The onset of clinical signs is variable from acute with a rapidly progressive course to slow, followed by a chronically progressive course. The former is more common. The clinical signs are extremely variable because they depend on the anatomic location of the lesions in the CNS. The acute lesion consists of a non-suppurative inflammation with parenchymal necrosis associated with extensive edema and occasionally hemorrhage. This may be extensive enough to be observed on transverse sections of the preserved brain and spinal cord as a gross enlargement and discoloration of the affected site in the CNS. The inflammation is mostly lymphoplasmacytic with numerous macrophages and scattered eosinophils, neutrophils, and multinucleated giant cells. Astrocytic scarring is common in chronic lesions. In untreated horses, the merozoites and schizonts may be found in macrophages and neurons are occasionally free in the parenchyma. Figures 11-25 through 11-34. Immunocytochemistry is now available to confirm this diagnosis and differentiate S. neurona from the much less common in hussey. The lesion is often well developed in one area of the CNS, where parenchymal necrosis is extensive, but the inflammation may also be quite widespread in the meninges and parenchyma without necrosis. Lesions occur in both gray matter and white matter and are often asymmetric in distribution. Occasionally, the lesion is almost limited to gray matter, which may result in an observable area of focal muscle atrophy. Asymmetry of clinical signs and focal muscle atrophy are clinical signs that are highly suggestive of this diagnosis. The most common location of the lesion is in the spinal cord followed by the caudal brainstem. It is least common in the prosencephalon. As with most inflammatory diseases, the anatomic diagnosis is completely dependent on the location of the lesion in the CNS, and the differential diagnosis depends entirely on the anatomic diagnosis. CSF is often normal despite the presence of inflammation in the leptomeninges. Occasionally, mild elevations are noted in protein and lymphocytes and macrophages. A polymerase chain reaction, PCR, test on CSF for the DNA of this organism will be positive only in the small percentage of horses in which the organism is present in the subarachnoid space. Therefore, the PCR test is impractical. Western blot immunoassay for antibodies in CSF is usually positive for horses with this disease, but false positives are common because obtaining a CSF sample from the lumbosacral subarachnoid space without some blood contamination is difficult. This test will be positive for the serum antibodies in CSF if the blood contamination is so small that CSF only contains 8 red blood cells, RBCs, per cubic millimeter, MM3. This factor makes the interpretation of any antibodies in CSF using this procedure unreliable. Cisternal CSF is less likely to have blood contamination, but general anesthesia is required to obtain CSF. More recently, an indirect fluorescent antibody test, IFAT, which is quantitative for whole merozoites and very resistant to blood contamination, has been developed. CSF antibodies are produced intrathecally. Using the IFAT, a ratio of serum to CSF antibody titers can be obtained. The normal ratio is 100:1. Any decrease in this ratio is thought to be diagnostic of an affected animal. A recent study has recommended using the ratio of serum antibodies and CSF antigen determined by the surface antigen 2,4/3 enzyme-linked immunosorbent assay, ELISA, for the diagnosis of CNS lesions caused by S. neurona. Remember that many horses are infected and have serum antibodies, but only a very few have the disease and produce intrathecal antibodies. The absence of any serum antibodies makes the presence of this disease highly unlikely. Be aware that these antibodies are passively transferred from the mare to her foal in the colostrum, and it may take up to 9 months for these serum antibodies to disappear from the foal's serum, although the mean time is 4.5 months. After infection, these antibodies can be detected for many years, even after removal of the animal from an endemic area. No definitive antemortem test exists for the diagnosis of this inflammatory disease. The antemortem diagnosis is most dependent on the presence of serum antibodies for S. neurona, the anatomic diagnosis, and the best judgment of the experienced clinician. Difficulty occurs when horses are presented for subtle gait abnormalities in which the orthopedic examinations are unrewarding. Many of these horses have been treated for protozoal myelitis with or without finding antibodies for S. neurona and CSF from a lumbosacral sample that is frequently contaminated by blood. We firmly believe that this diagnosis has often been made without justification because treatment is available. However, we also recognize that obtaining this justification is sometimes very difficult. Treatment consists of the oral administration of folate inhibitor drugs. The most common of these has been a combination of sulfadiazine and pyrimethamine. Other considerations include pontaziurol, diclazurol, toltrazurol, or nitazoxanide. Intravenous dimethyl sulfoxide is often used to reduce the vasogenic edema in acutely affected horses. Success of treatment depends on the severity and location of the lesions. Published results suggest that approximately 60% of horses with moderate to severe clinical signs will improve after treatment with any of the approved medications, and 10% to 20% will make a complete recovery. Long-term therapy for 3 to 6 months may be necessary to prevent relapses. Some investigators have recommended following the recovery with repeated analysis of CSF for antibodies and terminating the treatment when these disappear from CSF. Owners must be advised of the risk of using any presumably recovered patients for riding activity. Prevention of this disease depends on avoiding exposure to possums and contamination of the feed with their feces. Although this goal is difficult to achieve on pastures, at least the stored hay and grain can usually be protected from this source of contamination. A vaccine is available. For other examples of horses with clinical signs of myelitis caused by S. neurona, see video 5-52 in Chapter 5 and video 6-11 in Chapter 6. Video 11-10 shows an 18-month-old standardbred mare that suddenly became lame in the right thoracic limb 10 days before this examination. Within a few days, the gait was abnormal in the right pelvic limb. She occasionally fell when she moved suddenly to her right side, and she needed assistance to stand. The day before this examination, it was noted that she would sweat on the entire right side of her body, including the head. See figures 7-22 through 7-24 in Chapter 7. Note that the gait abnormality in this horse in video 11-10 is similar to that of this case example. See video 11-9. In addition, whole body sweating was noted on the right side and a mild atrophy of the right lateral scapular muscles. The anatomic diagnosis is the same as this case example, focal right C6, T2. The whole body, right side sweating is the result of a loss of the sympathetic system UMN pathways in the right cervical lateral funiculus. The age of the horse and the sudden onset of asymmetric clinical signs, including muscle atrophy, all make protozoal myelitis the most presumptive diagnosis and justifies therapy. With no response to treatment after 7 days, this mare was euthanized, and an autopsy confirmed the diagnosis of protozoal myelitis lesions primarily on the right side of the C6, C8 spinal cord segments. Video 11-11 shows Duke, a 4-year-old castrated male Belgian that suddenly had difficulty walking. Duke was kept out on pasture during the day with 3 other Belgians and was brought into the barn in the evenings. One evening, he did not show up at the pasture gate with the others and was found in the pasture reluctant to move, and when urged, his gait was abnormal. The video was made the next day. Note the right hemiparesis and ataxia, similar to this case example. See video 11-9, and the horse in video 11-10. The anatomic diagnosis was a focal or diffuse lesion on the right side of the cervical spinal cord, but we debated whether the cervical intumescence was involved. The right thoracic limb clinical signs probably represent a dysfunction of a combination of LMN and the UMN and GP systems. We noted that the tendency was less to overreach with that limb than to have difficulty supporting weight. With no more than 1 day of clinical signs, considering progression of signs in the differential diagnosis was impossible. Therefore, the differential diagnosis would include those described for this case example, as well as the acute, non-progressive disorders related to infection with the equine herpes virus 1 or ischemic myelopathy caused by fibrocartilaginous emboli. Neck injury in a horse of this size was considered highly unlikely. Duke's function was to pull wagons and sleighs filled with adults and children for various celebrations. The owner believed that the liability was too great to continue to use Duke regardless of the outcome of his clinical signs, and he was euthanized. At autopsy, numerous foci of ischemic myelopathy were observed on the right side of the C6, C8 spinal cord segments associated with fibrocartilaginous emboli in small arteries. Not enough is known about this syndrome in the horse to predict the outcome. However, in the case of dogs, many will spontaneously make a full recovery. Case example 11-3 signalment. 15-year-old female quarter horse. Furlong chief complaint, difficulty walking with the pelvic limbs. History. Furlong was used as a school horse in the morning. Late one afternoon, she suddenly began to sway and stumble in the pelvic limbs. She was hospitalized late that evening. Examination. C. Video 11-12 made 8 hours after the sudden onset without any significant change in the clinical signs. The examination was limited by the severity of her pelvic limb paresis and ataxia. Note the hypotonic tailing anus. During the examination, urine was excreted in brief bursts. On rectal examination, palpation revealed a distended bladder. Anatomic diagnosis. Focal or diffuse lesion between the T3 and L3 spinal cord segments and the sacrocaudal segments. The thoracic limbs appeared to be normal. The sacrocaudal clinical signs were mild. Differential diagnosis. Equine herpes virus 1 myelopathy, EPM, fibrocartilaginous embolic myelopathy, viral myelitis, rabies virus, WNV. The environment of this horse excluded consideration of an external injury. Neoplasia affecting the spinal cord of horses is rare and less likely to cause such an acute onset of clinical signs. A sudden intervertebral disc extrusion is also very rare in adult horses. Discus spondylitis is more common in foals and less likely to cause a sudden onset of clinical signs. Equine herpes virus 1 myelopathy. Equine herpes virus 1 myelopathy is the most presumptive clinical diagnosis. This viral strain is the most common cause of a vasculitis that affects the blood vessels of the CNS and reproductive tract of adult horses. The latter results in abortion. Clinical signs of involvement of the respiratory system with rhinopneumonitis are occasionally found. Equine herpes virus 4 is a common cause of rhinopneumonitis in young horses. Spinal cord lesions and clinical signs are the most common when the nervous system is affected by equine herpes virus 1. Brainstem and prosencephalic lesions and clinical signs occur but are rare. Clinical signs are always acute in onset and rarely progress for more than 2 to 3 days, which is typical for a vascular compromise. The clinical signs are usually symmetric, but asymmetric signs may occur as well. Viremia follows infection via the respiratory system, and infected leukocytes circulate to the vasculature of the nervous system. The primary virus-induced lesion is the result of this virus infecting the endothelial cells of the blood vessels in the nervous system, resulting in vasculitis and thrombosis. This vascular compromise causes ischemic or hemorrhagic degeneration, myelopathy, of the nervous system parenchyma. Inflammation is confined to the blood vessels, primarily in the leptomeninges. The clinical signs usually reflect the white matter lesions, which, in Furlong, the mare in this case example, were most severe in the thoracolumbar spinal cord segments. The severity of the clinical signs is determined by the summation of the ischemic lesions that are scattered through the white matter of the spinal cord. Individual ischemic lesions often have a linear appearance in the white matter that corresponds to the area supplied by a compromised penetrating artery from the vascular plexus on the surface of the spinal cord. See Figure 10-4 for the anatomy of the spinal cord blood supply and Figures 11-35 through 11-43 for the lesions. Mild sacrocaudal signs are common with this disorder but are difficult to correlate with lesions in these segments. The incontinence more likely reflects the involvement of the spinal cord tracts necessary for micturition, but the hypotonia and possibly hypalgesia of the tail, anus, and perineum remain poorly explained. C1 to C5 spinal cord lesions cause spastic tetraparesis and ataxia similar to horses with a malformation malarticulation disorder. When cervical spinal cord lesions are extensive, the patient will go down and be unable to stand. See Figure 11-40. Once recumbent, the horse is rarely able to stand again. Horses that remain standing after 3 days have a fair to good prognosis for spontaneous recovery. This status probably reflects the absence of ischemic necrosis, infarction, and the resolution of edema that may have developed at the sites of the ischemia. The severity of the clinical signs and the prognosis reflect the degree of vascular compromise to the CNS parenchyma. In mild cases that improve rapidly in approximately 7 days, the clinical signs may reflect only dysfunction and axonal depolarization caused by the energy loss as a result of the ischemia. With more severe ischemia, edema and axonal spheroids develop in the parenchyma, which may resolve over a few weeks. More extensive vascular compromise results in infarction, which is permanent. Most infected horses are mildly depressed. This disease often affects multiple horses on the same premises. Be aware that if you hospitalize such a horse, you place your other hospitalized patients at risk for this infection. Isolating infected patients is extremely important because they can readily pass the virus to other horses in aerosols of nasopharyngeal secretions or on feed, equipment, or the hands and clothes of individuals contaminated by these occur. Signs that are in their environment. Fever commonly precedes and may accompany the clinical signs of CNS infection and may be useful in determining early infection of a horse before the onset of clinical signs. Diagnosis is supported by demonstrating the presence of viral DNA or antigen in the buffy coat of serum or nasal secretions by PCR evaluation. Virus may be isolated from nasopharyngeal secretions. CSF often is xanthochromic, with an elevated protein level and a normal to slight elevation of the leukocyte count. No evidence-based data have been found to support specific antiviral therapy. Nursing care with special attention to the evacuation of urine is the most effective treatment. The results of vaccination to prevent the neurologic form of this disease have not been satisfactory. When an outbreak occurs on a farm, 1 to 6 weeks may pass before the clinical signs are seen in the last horse to be infected. Be aware that this virus often causes a persistent infection that may reactivate when the infected horse is stressed by such activities as excessive athletic exercise, transportation, or changes in farm management. Recrudescence may occur in a horse that has recovered from the clinical signs of this infection in its nervous system. EPM is a strong candidate for the anatomic diagnosis in for long. It can be ruled out by isolation of equine herpes virus 1 or identifying its DNA in nasal secretions or the absence of antibodies in the serum for S. neurona. The combination of a gait disorder typical of a lesion in the T3 to L3 spinal cord segments plus urinary incontinence and mild tail and anal hypotonia is very characteristic of a mild to moderate infection with the equine herpes virus 1 virus. As a rule, you would expect the clinical signs of a protozoal infection to continue to progress after the onset. Fibrocartilaginous embolic myelopathy, FCEM, causes a similar ischemic or hemorrhagic myelopathy of a few adjacent spinal cord segments with a sudden onset of clinical signs that rarely progress after 24 hours. It occurs in adult horses but is rare and would unlikely cause the unique anatomic diagnosis, as observed in furlong. In addition, no fever is noted in animals that have FCEM, and multiple animals are not affected on the same farm, as often happens with equine herpes virus 1 myelopathy. No ancillary procedure has been developed to support the diagnosis of FCEM in this horse because this region cannot be reliably imaged. Viral myelitis must be an initial consideration before you have time to observe whether the clinical signs will be progressive. Rapid progression to recumbency in 4 to 5 days would be expected with rabies myelitis. WNV myelitis usually causes progressive clinical signs, but this circumstance may vary considerably among infected horses. The most reliable way to rule down these causes of viral myelitis is to determine the presence of the equine herpes virus 1 virus in the patient. The horse in this case example did not improve over the next few days and was euthanized. An autopsy confirmed the diagnosis of ischemic myelopathy associated with vasculitis with herpes virus 1 identified in the endothelial cells by immunocytochemistry. Case example 11-4 signalment. 14-year-old female Oldenburg warm blood. Charisma chief complaint. Abnormal pelvic limb gait history. Charisma was a Grand Prix jumper whose performance as well as her pelvic limb function began to deteriorate 3 months before this examination. All orthopedic examinations were normal. Examination. See video 11-13. Note that the thoracic limbs are normal, and if you were leading this horse, you would better appreciate the severity of the pelvic limb paresis and ataxia. If this horse were turned vigorously, she would go down and need help to stand. Note the presence of a presumptive melanoma in the perineal area. Anatomic diagnosis. Focal or diffuse spinal cord lesion between the T3 and L3 spinal cord segments. Differential diagnosis. Neoplasm, melanoma, EPM, intervertebral disc extrusion protrusion, discus spondylitis equine herpes virus 1 myelopathy and FCEM were excluded only because they cause an acute onset of non-progressive neurologic signs. The prolonged course of this anatomic diagnosis made a viral myelitis most unlikely. Neoplasm, melanoma, at T17 metastatic melanoma is the most presumptive clinical diagnosis for charisma based on her age, color, and primarily the presence of melanomas in her perineal area. Other extraparenchymal neoplasms compressing the spinal cord are uncommon. In the absence of these recognizable melanomas, a slowly progressing protozoal myelitis would be a strong consideration, providing that she had serum antibodies for S. neurona. Intervertebral disc extrusion protrusion is rare in horses, even at this age. Discus spondylitis is uncommon at this age, would unlikely be this chronic, and should cause considerable discomfort. Charisma was too large for imaging studies. A vaccine was made to treat her melanoma, but the treatment was unsuccessful. When she became unable to stand on the pelvic limbs even when assisted, she was euthanized. At autopsy, melanomas were found diffusely distributed through the thoracolumbar axial muscles, and an extradural melanoma was present in the vertebral foramen of T17, which displaced and compressed the adjacent spinal cord. Figure 11-44. T17 fracture in a full C. Video 11-14 of a 1-month-old thoroughbred colt that was found down at pasture after a severe thunderstorm. The video was made approximately 24 hours later. Manipulation of the colt was restricted because a fracture was suspected. Note the extension of the thoracic limbs but also their vigorous voluntary movement along with neck flexion while the colt remained recumbent. Note also the absence of any voluntary movements with the pelvic limbs. This thoracic limb extension represents the Schiff-Sherrington syndrome that is present. This syndrome is described in Chapter 10. No evidence was found of any spinal shock in this colt. Note the preserved muscle tone and spinal reflexes in the pelvic limbs, tail, and anus and the analgesia caudal to align at the level of the caudal thoracic vertebrae. A caudal thoracic spinal cord transverse lesion was diagnosed, and radiography revealed a compression fracture of T17 with displacement into the vertebral canal. Decompressive surgery revealed severe hemorrhage and softening of the spinal cord at the fracture site, and the colt was euthanized. A lack of bone density in foals and young farm animals places them at risk for fractures when they fall. Presumably, this foal's injury was related to a fall associated with the excitement caused by the thunderstorm. Cervical scoliosis, Parallelophastrongylus tenuis C. Video 11-15 of Thor, a 2-year-old castrated male mixed breed horse with a chief complaint of a bent neck. The abnormal curvature of the neck was first observed 5 days before this examination, and a mild gait abnormality was suspected for approximately 2 days. In the video, note the scoliosis of the cervical vertebrae with a concavity on the left side. Also note the mild clinical signs of UMN and GP dysfunction in the right limbs and the analgesia of the right side of his neck. By the time this video was made, Thor had developed a strong objection to our testing of his analgesia, which extended from approximately the level of his atlas to the mid-thoracic trunk on the right side only. Scoliosis is an uncommon clinical sign in the adult horse. Most publications that describe the basis for scoliosis in animals indicate that it is the result of denervation of the muscles on one side of the neck, and the scoliosis is the result of the unopposed muscle contractions on the opposite side, the side toward which the scoliosis is directed. This assumption is reasonable, and to explain the scoliosis in Thor, an autopsy should reveal a lesion in the right ventral gray column or the intraparenchymal axons of the right ventral roots. The right side area of analgesia would require a right side dorsal gray column lesion from approximately C2 to approximately T10, and the right side UMN and GP system dysfunction requires at least a mild right side white matter lesion at some level in the cervical spinal cord segments. We have observed scoliosis in 4 other horses that had cervical spinal cord lesions confined to the area of the dorsal gray column of multiple segments on one side. No ventral gray column lesions were noted. The concavity of the scoliosis was always opposite to the side of the lesion, which meant that their necks flexed laterally away from the side of the lesion. A similar clinico-anatomic relationship has been observed in humans and experimental animals. The assumption is that this lesion interferes with the afferents from neuromuscular spindles that are involved with the stretch reflexes necessary to maintain muscle tone. The disparity in muscle tone would account for the deviation of the cervical vertebrae to the side opposite to the lesion. A dorsal gray column lesion over multiple segments would cause an ipsilateral hypalgesia or analgesia. The extension of this lesion into the adjacent lateral funiculus would explain the mild right side spastic hemiparesis and ataxia observed in Thor. The lesion that we have observed in all of these horses consisted of a continuous non-suppurative inflammation associated with scattered areas of necrosis centered in the dorsal gray column on one side of the cervical spinal cord with variable extension into the adjacent white matter. A few eosinophils were present in the inflammation. This lesion has the appearance of a parasitic tract similar to what we commonly see in small ruminants in camelity caused by the migrating larvae of Pyrrhelophus strongyus tenuis, P. tenuis. In these species, the lesions are not confined to the dorsal gray column. The life cycle of this parasite is described with the spinal cord diseases of farm animals in this chapter. Thor was euthanized, and this inflammatory destructive lesion was found in the dorsal gray column and adjacent white matter on the right side of the spinal cord from C2 to the caudal thoracic spinal cord segments. In the C5 spinal cord segment, transverse sections of a parasite were found and identified as a protostrongylid nematode, presumably a larva of P. tenuis. Figures 11-45 through 11-49. Farm animal spinal cord disease case example 11-5 signalment. 3-year-old castrated male llama. Rocky chief complaint. Abnormal use of the pelvic limbs history. The difficulty using the pelvic limbs developed rapidly over 3 days, and he now needs assistance to stand on the pelvic limbs. Examination. C. Video 11-16. Anatomic diagnosis. A focal or diffuse lesion in the spinal cord between the T3 and L3 segments. Differential diagnosis. P. tenuis myosis. Discus spondylitis. Vertebral malformation. Intervertebral disc extrusion protrusion. Neoplasia because of the 3 days of progressive clinical signs. External injury was excluded. We have not diagnosed FCEM in any ruminant or camelity. In this species, myosis with the larvae of P. tenuis is, by far, the most presumptive clinical diagnosis for this llama, given that it is a very common disease in the northeastern states, where the white-tailed deer are common. Discus spondylitis is a worthy consideration and would require radiography for confirmation. Clinical signs of spinal cord compression by a vertebral malformation usually occur before 1 year of age. Both intervertebral disc extrusion protrusion and neoplasia are rare in this species and would not be expected at this age. We have not made these diagnoses in any species of camelity. Listeriosis more commonly occurs in the brainstem than the spinal cord. Pyrrhelophus strongylis tenuis, P. tenuis. Myosis P. tenuis infection is a common disorder of sheep, goats, and camelity. Although P. tenuis infection is rare in cattle, it has been reported. It has recently been described in the horse. See Video 11-15 in the section on equine spinal cord diseases in this chapter. Clinical signs may reflect parasite migration in any part of the CNS, but spinal cord signs are most commonly observed. P. tenuis is a protostrongylid nematode, the primary host of which is the white-tailed deer, in which the parasite is called the meningeal worm. The intermediate host is the slug or snail. P. tenuis is present in North America wherever the white-tailed deer are located. The small ruminant or camelity is an aberrant primary host in which the life cycle is not completed. In the normal life cycle, the first stage larva is passed in the feces of the primary host, the white-tailed deer. This first stage larva enters the footpad of the intermediate host, the slug or snail. Over the next 2 to 3 weeks, 2 molts occur, resulting in the formation of the infective third stage larva. The white-tailed deer eats the infected slug or snail or ingests their slime secretions that contain the third stage larva that contaminates the grass eaten by the primary host. The third stage larva enters the intestinal epithelium and migrates through the intestinal wall into the mesentery or into the peritoneal cavity. The migratory route from there to the vertebral canal is unknown. The third stage larva enters the spinal cord and is thought to develop in the dorsal gray column to a fourth stage larva. It then migrates into the subarachnoid space and enters the cranial cavity, where it molts into a fifth stage larva, which is the adult form of the parasite. The adult is a long, very thin, thread-like structure located in the intracranial subarachnoid space or a venous sinus. Following copulation, the eggs are deposited into a venous sinus, from where they circulate as emboli to the lungs. In the lungs, they lodge in capillaries and become incorporated into granulomas. The eggs hatch and release first-stage larvae that escape from the granuloma and penetrate the alveoli. They enter the airway and migrate by mucociliary action to the pharynx, where they are swallowed and ultimately excreted by the white-tailed deer. When the third-stage larva is ingested by the aberrant primary host, the sheep, goat, alpaca, llama, reindeer, caribou, moose, fallow, or mule deer. The larva penetrates the intestinal wall and migrates via an unknown route to the spinal cord. The larva enters the spinal cord, where it migrates, causing necrosis and non-suppurative inflammation with eosinophils. Migration and lesions may occur in the brainstem. Resultant clinical signs often reflect involvement of the medulla with vestibular dysfunction and facial paralysis or paresis. The life cycle is interrupted at this stage, when large quantities of third-stage larvae were fed to sheep and goats. The shortest time between the feeding and the observation of clinical neurologic signs was 11 days. Figures 11-50 through 11-53. Clinical signs most commonly reflect the development of spinal cord lesions at any level. Brainstem signs occasionally occur, but cerebral signs are rarely observed, despite what we have observed in horses that have this parasite. Scoliosis is uncommon in these ruminant and camelid species. The presence of a pleocytosis in the CSF that contains eosinophils is strongly supportive of this diagnosis. However, the absence of eosinophils in the CSF does not deny the diagnosis. Despite available treatment with various anthelmintics such as fenbendazole or ivermectin, the prognosis is guarded once neurologic signs develop. The best prevention is to avoid exposure of the aberrant primary host to the feces of the white-tailed deer. A few preventative farm management practices include avoiding pastures that border on woods inhabited by white-tailed deer, fencing off hot terrace with deer fencing, and keeping a dog with the animals on the pasture as well as guinea hens or ducks to eat the slugs and snails. When this is not practical, rigorous preventative therapy with anthelmintics such as ivermectin every 30 to 45 days from spring to fall may prevent the development of CNS lesions. For other examples of this parasitic infection, see the following videos. Video 11-17 shows an adult female Toggenburg with 2 weeks of a progressive gait abnormality in all 4 limbs resulting in recumbency. She was the 10th goat on the farm to be affected with primarily spinal cord signs over the last few weeks in the late summer and early fall. Note the non-ambulatory tetraparesis and the presence of enough spasticity for this doe to support herself unassisted. Your anatomic diagnosis should be a focal or diffuse lesion in the spinal cord between the C1 and C5 segments. Her lumbosacral CSF sample contained numerous eosinophils. Video 11-18 shows a group of adult llamas that were fed third-stage larvae as part of an experiment on the pathogenesis and diagnosis of P. tenuismyosis. Note the one adult llama with the mild neurologic signs. Also note her tendency to overreach with the thoracic limbs, indicating that at least one lesion is located in the cervical spinal cord white matter between the C1 and C5 segments. The more severe pelvic limb signs may still be caused by the cervical spinal cord lesion or may reflect another lesion between the T3 and L3 spinal cord segments. Video 11-19 shows Marie, an adult female llama, with a 1-week history of progressive difficulty using her pelvic limbs. Compare her thoracic limb gait with the previous llama in Video 11-18. Marie's thoracic limb function is normal. Her anatomic diagnosis should be a focal or diffuse spinal cord lesion between the T3 and L3 segments. Eosinophils were present in her lumbosacral CSF sample. Video 11-20 shows Dolly, a 2-year-old female alpaca with a rapid onset of a bump on the left side of her neck approximately 10 days before this examination, during which little change in the neck posture was noted. The bump on her neck is a cervical scoliosis that is similar to that seen in the horses we have studied that have a parasitic tract lesion in their dorsal gray column on one side, which we believe is caused by the migration of P. tenuis in this species. Dolly did not exhibit any other neurologic signs. We did not detect any hypalgesia or analgesia in her neck. The scoliosis with a convexity on the right suggests a left side gray matter lesion in the C1, C5 spinal cord segments. Her CSF had a pleocytosis with numerous eosinophils. Despite how common this parasitic myosis is in the CNS of camelidae, sheep, and goats, scoliosis is an uncommon sign in these species. Vertebral malformation. Video 11-21 shows Buddy, a 4-month-old male alpaca shria, with a 3-week history of progressive pelvic limb dysfunction resulting in paraplegia. Note the mass reflexes that a noxious stimulus elicited. Nociception was severely compromised, but we were not sure if analgesia was present in the pelvic limbs. The anatomic diagnosis was a focal or diffuse spinal cord lesion between the T3 and L3 segments. Radiography showed a mid-thoracic vertebral malformation with kyphosis that was responsible for severe spinal cord compression. Case example 11-6 signalment. 3-month-old female Toggenburg goat chief complaint, inability to stand history. The goat suddenly was observed to drag her right pelvic limb, which rapidly progressed within 1 day to difficulty using both pelvic limbs, and the following day, she was unable to stand. She was presented on the 3rd day recumbent and unable to stand. Examination. See Video 11-22. This kid is alert and responsive and was normal cranial nerves. Note the non-ambulatory tetraparesis with no voluntary limb movement when held up but vigorous pelvic limb movement in response to a noxious stimulus when recumbent. Also note that the patellar reflexes were present and normal only in one recumbency. The explanation for this circumstance is unknown, but it emphasizes the importance to always test them in both recumbencies before considering them to be absent. Note the discomfort that occurred on flexing the neck when pressure was applied to the caudal cervical vertebrae. Also note the thoracic limb hypotonia, abnormal withdrawal reflexes, and mild bilateral atrophy of the lateral scapular and triceps muscles. Anatomic diagnosis. A focal spinal cord lesion between the C6 and T2 segments or multifocal spinal cord lesions that include the segments the mild thoracic limb hypotonia, the lack of their withdrawal from a noxious stimulus, and, instead, an extension of the limbs, and a mild bilateral atrophy of the lateral scapular and triceps muscles all suggest an LMN component to their paresis. The lack of any voluntary effort to move the limbs when held up also implicates the UMN system in the severe paresis. Differential diagnosis: myelitis caused by the caprine arthritis encephalitis virus, P. tenuis, discus spondylitis, vertebral malformation, copper deficiency, and zootic ataxia. Organophosphate toxicity. Caprine arthritis encephalitis virus. Caprine arthritis encephalitis, KI, is a multisystem viral disease of goats caused by a lentivirus, a type C retrovirus that is related to the visnovirus of sheep. In addition to causing a demyelinating leukoencephalitis of young goats, this virus causes pneumonitis, arthritis, and mastitis of older adult goats. The virus is transmitted not only from an infected goat or kid in the colostrum and milk but also by direct contact transmission. The neurologic disease usually occurs between 1 and 6 months of age, is acute in onset, and is rapidly progressive. Lesions may be focal, multifocal, or diffuse in the CNS, with the spinal cord most commonly affected. The caudal brainstem is occasionally affected but rarely the prosencephalon. Although the initial action of the virus is to cause a primary demyelination, this phase is rapidly followed by an extensive inflammatory response that is considered to be a cell-mediated immunopathologic response. This inflammation is non-suppurative, with massive accumulations of mononuclear cells in a perivascular location, as well as throughout the involved parenchyma, where necrosis is extensive. Lesions predominate in the white matter, but extensions into the adjacent gray matter also occur. Focal lesions are often recognized on gross examination of the preserved spinal cord or brain. Slight enlargement of the affected area will be noted, and on transverse section, this area will be firm with a yellow to tan discoloration. Figures 11-54 through 11-59. Usually, the extent of the neurologic dysfunction results in euthanasia. If the patient is allowed to survive, the progress of the disease may cease, but any significant recovery rarely occurs. The anatomic diagnosis is determined by the location of the lesions. The diagnosis is dependent on determining the presence of serum antibodies to this virus. Herd infection is common because this virus may persist without causing disease. Therefore, the presence of the serum antibodies indicates only infection and not necessarily the disease. The factors that are responsible for the onset of disease in an individual animal are unknown. The CSF reflects the massive inflammation that is present in the CNS lesions that include the meninges with markedly elevated protein and mononuclear cells. Eosinophils are not part of this inflammation. Thus, this diagnosis is supported by the CSF abnormalities in the presence of serum antibodies. Prevention of this disease is dependent on the elimination of any goat from the herd that contains antibodies for the key virus. Before accomplishing this task, any kid born from a doe with these serum antibodies should be immediately removed from that doe at birth and be fed milk from an uninfected doe. P. tenuis is a strong candidate for the clinical diagnosis in this kid. Only the age makes a key viral myelitis more likely. The presence of eosinophils in the CSF would also support the myosis. Discus spondylitis is also a strong consideration at this site at this age and with the observation of neck discomfort. CSF should be normal or only slightly altered. Radiography is usually diagnostic in cases of discus spondylitis. Vertebral malformation with secondary compressive myelopathy is uncommon at this site. We have seen malformation with subluxation at the C2, C3 articulation in a few goats. See the following videos of other goats with key viral myelitis. Video 11-23 shows a 3-month-old female Toggenburg kid with 3 days of a progressive gait disorder. From your study of this video, you should recognize a right-side spastic hemiparesis and ataxia. Patellar reflexes are brisk, and flexor reflexes are normal, as is nociception. This information should help make the anatomic diagnosis of a right-side focal spinal cord lesion between the C1 and C5 segments. The rapid course of a focal, asymmetric lesion at this age strongly implicates a diagnosis of key myelitis. Serum antibodies for the key virus were found, and the CSF contained 40 mg per deciliter, mgdl, of protein, 7 RBCs MM3, and 23 white blood cells, WBCs, MM3, with 100% mononuclear cells. This kid was euthanized, and the diagnosis of key myelitis was confirmed at autopsy. Figures 11-60 and 11-61 show the unilateral midcervical spinal cord key myelitis that caused this spastic hemiparesis and ataxia. Video 11-24 shows a 2-month-old female Toggenburg with 10 days of a progressive gait disorder resulting in recumbency 4 days before this examination. Note the spastic tetraplegia. Your anatomic diagnosis should be a focal or diffuse spinal cord lesion between the C1 and C5 segments. The rapid clinical course and age of this patient make key myelitis a strong consideration for the clinical diagnosis. Serum antibodies for this virus were found, and the CSF contained 655 mgdl of protein, 54 RBCs MM3, and 73 WBCs MM3, with 75% monocytes and 25% lymphocytes. She was euthanized, and a diffuse non-suppurative myelitis was diagnosed in numerous spinal cord segments that was compatible with a diagnosis of key myelitis. Video 11-25 shows Maggie, a 9-year-old female mixed-breed goat with a 2-month history of an initial acute onset and rapid progression of loss of pelvic limb function. This phase was followed by some improvement and then regression of clinical signs. Note the severe spastic paraparesis and pelvic limb ataxia, grade 1 using the small animal scale for function, and the normal function of the thoracic limbs. Your anatomic diagnosis should be a focal or diffuse spinal cord lesion between the T3 and L3 segments. Differential diagnosis includes P. tenuis, myelitis caused by the key virus, discus spondylitis, and neoplasia. The serum contained antibodies for the key virus. The CSF contained 155 mg of protein DL, 2 RBCs MM3, and 22 WBCs MM3, with 90% lymphocytes and 10% monocytes. This inflammatory response in CSF and the absence of eosinophils make acute viral myelitis the most presumptive clinical diagnosis in this goat. However, this goat was older than most goats that we see with this disease, and the absence of eosinophils in the CSF does not rule out P. tenuismyosis. No further studies were conducted to confirm the diagnosis. Copper deficiency in zootic ataxia. Copper deficiency in zootic ataxia is seen as an acquired disease in young sheep and goats and occasionally pigs, with an onset of a slowly progressive paraparesis and pelvic limb ataxia at 2 to 4 months of age. Clinical signs are symmetrical and usually reflect a UMN, quality paresis, and a GP system ataxia. Occasionally, LMN signs are observed. As the disease progresses, the thoracic limbs will become involved. The lesion is a dying back axonopathy of CNS neurons and a secondary demyelination and astrogliosis in the spinal cord. Neuronal cell bodies in the brainstem and spinal cord ventral gray columns may undergo chromatolysis and eventual necrosis. In the kid in this case example, 11-6, the rapid progression of the clinical signs and the focal nature of the anatomic diagnosis make copper deficiency an unlikely diagnosis. Organophosphate toxicity. Organophosphates may cause a delayed form of toxicity that results in asymmetric spastic paraparesis and pelvic limb ataxia. Case example 11-6. These clinical signs may not occur until 3 to 5 weeks after using an organophosphate anthelmintic. Haloxin has been most frequently implicated, but other triorthocrysyl phosphate forms may also exhibit this delayed form of toxicity. As a rule, the clinical signs occur rapidly and then remain static and limited to the pelvic limbs. Some sheep may be resistant to this toxicity based on the level of their plasmaesterase. A similar organophosphate-induced spinal cord disorder occurs in cattle. By the time the clinical signs are recognized, significant reduction of the serum cholinesterase levels does not usually occur. In the kid in this case example, key viral antibodies were in the serum, and the CSF contained 246 mg/dl of protein, normal, 40, 76 RBCs MM3, and 315 WBCs MM3, normal, 5, with 72% macrophages and 28% lymphocytes. Key myelitis was considered the presumptive clinical diagnosis. This kid was euthanized, and this diagnosis was confirmed at autopsy. See figures 11-54 through 11-56. Case example 11-7 signalment. 2-month-old female Holstein chief complaint. Abnormal gait history. The gait abnormality had been slowly progressing for at least 2 weeks. Examination. See video 11-26. Note the delay in the onset of protraction and the long strides in all 4 limbs with the overreaching action in the thoracic limbs, especially on turning. Anatomic diagnosis. Focal or diffuse spinal cord lesion between the C1 and C5 segments. Differential diagnosis. Discus spondylitis or vertebral canal abscess. Lymphosarcoma. Hepatic encephalomyelopathy. These progressive clinical signs at this age are most commonly caused by a hematogenous bacterial infection causing discospondylitis or an abscess that has developed within the vertebral canal or adjacent to the vertebral column with extension into the vertebral canal. Lymphosarcoma most commonly occurs in the extradural space of adult cattle at any level of the vertebral canal and causes a compressive myelopathy. This type is termed the enzootic form of lymphosarcoma, which is caused by the bovine leukemia virus in cattle that are usually older than 4 years. A sporadic form occurs in cattle younger than 3 years but is much less common. In this 2-month-old calf, no fever was noted, nor were any systemic signs of an infection in the CBC. CSF was normal. Radiography was normal as was the CSF evaluation. Hepatic encephalomyelopathy in a calf. The owner of this heifer calf elected euthanasia. Autopsy showed no gross lesions of any component of the CNS, but the liver was small. On microscopic examination, the changes in the liver supported a portosystemic shunt, which had been overlooked at autopsy. The entire CNS had an extensive dilation of the myelin sheaths, which was especially profound in the spinal cord, with diffuse liver dysfunction that causes neurologic signs from hepatic encephalopathy. 2 microscopic changes can be seen in the CNS. All species show a change in the nuclei of the astrocytes that reflects their reaction to the increased levels of circulating ammonia and other metabolites not cleared by the liver. In human neuropathology, these abnormal astrocytes are termed Alzheimer astrocytes. The other CNS lesion of hepatic encephalopathy that is observed in all species except the horse is a fluid accumulation within the myelin lamellae, causing a dilation of the myelin sheath that is sometimes called polemic recavitation. This myelin lesion is most extensive in cattle and was severe enough in the spinal cord of this calf to explain the clinical signs that were observed. As a rule, you would expect to observe episodic prosencephalic signs in this metabolic disorder, but none of these was observed in this calf. We are now aware of calves studied at other hospitals that exhibited cervical spinal cord signs with a portosystemic shunt and similar CNS lesions. These shunts are most common in dogs that exhibit episodic clinical signs of prosencephalic dysfunction with no indication of any spinal cord dysfunction. The extent of the myelin sheath dilation in the CNS in dogs with hepatic encephalopathy is much less than in cattle. This bovine case was an eye-opener for us, a live and learn case that keeps one humble. In retrospect, subtle clinical pathology alterations were present and should have prompted evaluation of bile acid metabolism and blood ammonia levels. See video 11-27 of a 1-month-old female Holstein that became unable to stand using its pelvic limbs over a 1-week period. The severe spastic paraparesis and pelvic limb ataxia justify the anatomic diagnosis of a focal or diffuse spinal cord lesion between the T3 and L3 segments. Radiographs, see video, show discus spondylitis at the T13, L1 articulation with a compression fracture of T13. Video 11-28 shows a 6-year-old Holstein cow with 5 days of a progressive gait abnormality. Study the video. The cranial nerve examination was normal. Your anatomic diagnosis should be a focal or diffuse spinal cord lesion between the C1 and C5 segments. The two most common causes of progressive focal spinal cord disease in Holstein cattle are discus spondylitis in young animals and lymphosarcoma in older cattle. This cow was euthanized, and an autopsy showed an extradural lymphosarcoma compressing the spinal cord in the foramen of C4. Brown Swiss myelopathy. Be aware that many inherited neurologic disorders of the CNS of brown Swiss cattle have been described. An autosomal recessive inherited motor neuron disease, often called spinal muscular atrophy, was discussed in Chapter 5. The term Weaver has been used for a slowly progressive degenerative myeloencephalopathy that is inherited as an autosomal recessive genetic disorder. This neurologic disorder is an axonopathy with secondary demyelination and astrogliosis and with onset of UMN and GP system dysfunction in the pelvic limbs at 5 to 8 months of age. After weeks of progression, clinical signs of mild thoracic limb dysfunction may be noted. These cattle become unable to stand on the pelvic limbs by 18 to 36 months of progression. A congenital axonopathy has also been described in brown Swiss calves that are born down unable to stand with clinical signs of diffuse UMN and GP system dysfunction and lesion distribution similar to the late onset axonopathy just described. Some of these calves exhibit opisthotonos and extensor rigidity of the limbs. Whether the late onset axonopathy and the congenital axonopathy are the same disease process remains to be determined. Charolais leukodystrophy in Charolais cattle, a diffuse CNS white matter oligodendroglial dysplasia occurs, with an onset between 1 and 2 years of age, and causes a slowly progressive spastic paraparesis and pelvic limb ataxia. These clinical signs of spinal cord disease slowly progress from the pelvic limbs to the thoracic limbs, and recumbency may follow. Female cattle exhibit an unusually rhythmic, pulsatile form of urination. Charolais leukodystrophy appears to be a disorder of pyramidal myelin, with whorls of hypertrophic oligodendroglial cell membrane and cytoplasm developing at the nodes of Ranvier. These plaques of myelin dysplasia most common in the spinal cord funiculi, cerebellar medulla, optic tracts, internal capsule, and corpus callosum. This disorder is presumed to be the result of an inherited disorder in the Charolais breed. However, we have seen the same lesion in an 18-month-old Hereford, which had a gait abnormality and was called in the surveillance for bovine spongiform encephalopathy at a western New York packing plant. Case example 11-8 signalment. 1-year-old female Holstein chief complaint, abnormal gait history. This heifer was one of a small group of heifers on a partially wooded pasture in Australia, where they were observed only sporadically. At one of these observations, it was noticed that this heifer had an abnormal gait. Examination. See video 11-29. Note the difference in the protraction phase of the gait between the pelvic and thoracic limbs. Anatomic diagnosis. Focal cranial thoracic spinal cord segments. This gait fits the pattern of what is termed a two-engine gait, which was described in Chapter 10. The pelvic limb dysfunction clearly indicates an interruption in the UMN and GP systems, which normally control their voluntary movements. As a rule, the short strides in the thoracic limbs reflect loss of a portion of their LM and innervation of extensor muscles necessary for weight support. This loss would be explained by a mild lesion in the C6 to T2 spinal cord segments involving both gray and white matter. However, the short-strided thoracic limbs may also reflect a cranial thoracic lesion that causes discomfort or causes a loss of the UMN and GP systems that control axial muscles at a cranial thoracic level. In this video, you will recognize that when this heifer stood up after being down or when she tried to prevent herself from falling after stumbling, the thoracic limb strength that she exhibited was remarkable and did not exhibit any indication of an LMN paresis. Differential diagnosis. Because of the limited observation of this heifer, the nature of the onset and course of these clinical signs was unknown. Fracture, discus spondylitis, abscess in the vertebral canal and lymphosarcoma are all responsible considerations. T4 fracture in a cow. The last two differential diagnoses for case example 11-8 were briefly described in case example 11-7. No ancillary procedures were available for further study of this heifer. She was euthanized, and had autopsy. A fracture of the T4 vertebra was diagnosed, with partial displacement into the vertebral canal. Microscopic examination of the vertebral body showed no evidence of osteomyelitis. We thank Dr. Brian Farrow of Sydney, Australia, for this video and arranging for this autopsy study. See video 11-30. This 3-year-old female Angus was found down at pasture. If you just observe this cow over the fence, you will have no indication of the anatomic location of the neurologic disorder. In the initial portion of the video, her recumbent posture might suggest opisthotonos and extensor rigidity, or the thoracic limb extension might suggest the Schiff-Sherrington syndrome. With the help of the hip lifter, her paraplegia can be seen, and she has normal use of her thoracic limbs, head, and neck, which still supports the possibility of the Schiff-Sherrington syndrome. Spinal nerve reflexes were difficult to evaluate in the pelvic limbs because of the hypertonia. They were intact in the tail and anus. Hypalgesia was severe caudal to the cranial-lumbar area. Radiography revealed a fracture of the L3 vertebra with displacement into the vertebral canal. Case example 11-9 signalment. 5-year-old female Holstein chief complaint, abnormal use of the pelvic limbs history. This cow's ability to use her pelvic limbs deteriorated over 5 days, resulting in her inability to stand on the 4th day. Examination. See video 11-31. Before this video was made, when the pelvic limbs were assisted with the hip lifter, she was able to stand with her thoracic limbs. Note the repetitive flexion exhibited in both pelvic limbs that alternates between the two limbs. This flexion resembles an equine string halt action, as well as the continuous action seen with myoclonic syndrome in dogs. Remember that in horses and, to a lesser degree, in cattle, the anatomic reciprocal apparatus functions in the pelvic limbs. Therefore, any stifle flexion will result in simultaneous flexion of the tarsus and fetlocks. Tail tone was mildly depressed, but the perineal reflex was intact. Nociception seemed depressed in the sacrocaudal nerve distribution. The bladder was enlarged on rectal examination. Anatomic diagnosis: lumbosacrocaudal spinal cord segments. The repetitive string halt type myoclonic action suggests a disturbance in the central pattern generator of the pelvic limbs in the caudal, lumbar and sacral segments. Assessing the cranial extent of the spinal cord lesion was not possible. Differential diagnosis: lymphosarcoma, discospondylitis, rabies myelitis. Extradural lymphosarcoma is the most common cause of clinical signs of spinal cord dysfunction at any level in the adult cow. The virus-associated enzootic form would be expected at her age of 5 years. Discospondylitis commonly occurs at the lumbosacral articulation but may occur at any level of the vertebral column. It is more common in calves, and at the lumbosacral articulation will only affect the sciatic nerve contribution to the gait unless the infection spreads cranially within the vertebral canal. With a lesion confined to the lumbosacral articulation, this cow should be able to stand and walk. See Video 11-32 for this comparison. Rabies myelitis. The most common cause of myelitis in cattle is infection with the rabies virus. This neurotropic virus affects neuronal cell bodies and gray matter at all levels of the CNS. Clinical signs may initially reflect spinal cord dysfunction, but the disease usually progresses rapidly to cause clinical signs of brainstem and cerebral dysfunction. Clinical signs limited to spinal cord dysfunction are unusual. However, a loss of tail tone is often observed in cattle with intracranial signs of rabies encephalitis. By the time the rapidly progressive disease affects the brainstem, many of the spinal cord signs may be masked. CSF contained a normal protein level, with 26 WBCs MM3, and consisted of 26% macrophages and 74% lymphocytes. This cow was euthanized, and had autopsy. Non-suppurative myelitis was seen scattered through most of the lumbosacrocaudal segments, accompanied by viral inclusions in neuronal cell bodies, Negri bodies, which immunocytochemistry confirmed to be rabies virus. Always include rabies in your differential diagnosis in any species. Lumbosacral discospondylitis in a cow. Video 11-32 showed a 2-year-old female Holstein with a rapidly progressive abnormal gait in both pelvic limbs for the previous 4 days. Note the ability to protract the limbs by hip flexion, intact lumbar nerves and spinal cord segments, and support weight, intact femoral nerves, L4, L5 spinal cord segments, but overflexed tarsi and a tendency to buckle dorsally at the fetlocks. Tibial nerve dysfunction, S1, S2 spinal cord segments, loss of tail tone, deficiency of caudal nerves or spinal cord segments, and possible hypalgesia of anus, perineum, and caudal thighs, deficiency of sacral nerves or segments. The degree of hypalgesia was difficult to assess because of the stoic behavior of this cow. On attempting to obtain CSF at the lumbosacral site, a suppurative exudate was aspirated. Radiography showed discospondylitis of the lumbosacral articulation. This cow was euthanized, and autopsy confirmed the discospondylitis, as well as extension of the suppurative inflammation into the vertebral canal where it surrounded the sacrocaudal segments and spinal nerves. 2 months before this disorder was diagnosed, the tail was removed by elastic band occlusion of its blood supply. Case example 11-10 signalment. 4-month-old female Montevideo lamb. Chief complaint: inability to stand unassisted. History: this lamb developed difficulty walking with all 4 limbs 1 week before this examination. Her abnormal gait progressed rapidly and she had been unable to stand unassisted for 2 days. The owner also commented that the right ear had been drooped for approximately 1 month. Examination: see Video 11-33. Note the disparity in the function of the thoracic limbs compared with the pelvic limbs and the loss of muscle tone and withdrawal reflexes only in the thoracic limbs. In the cranial nerve examination, note the absent right eyelid closure when the lids are touched but the eyeball still retracts. Sensory nerve is intact or when the U is menaced. Vision is intact. On neck extension and ruminants, the eyeballs do not normally elevate, and sclera is visible in the palpebral fissure, which is the opposite response seen in small animals. In this U, the right eyeball elevates on neck extension, which suggests some disturbance in the peripheral or central components of the vestibular system on the right side. Anatomic diagnosis: focal lesion in spinal cord segments C6, T2 plus the right facial nucleus or nerve and possible vestibular system components. The severity of the clinical signs caused by the spinal cord lesion prevents the recognition of any clinical signs that may be in the middle affecting the UMN and GP systems, where the facial nucleus is located. The separation in time between the observation of the facial paresis and the onset of clinical signs of spinal cord dysfunction suggests that these clinical signs may be unrelated. Differential diagnosis: discospondylitis with otitis media interna, P. tenuismiosis, listeriosis, copper deficiency with otitis media interna, and selenium toxicity with otitis media. In turn, if we consider that the facial paralysis and the suggestion of a vestibular nerve dysfunction are secondary to otitis media interna, then discus spondylitis of the caudal cervical vertebrae is the most presumptive clinical diagnosis that needs to be considered. P. tenuis myosis is still a strong consideration, but the severity of the LM and clinical signs in the thoracic limbs would be unusual. The rapid clinical course of the spinal cord lesion and the disparity in the dysfunction between the thoracic and pelvic limbs would not be expected with copper deficiency. Sudden onset of LM and dysfunction in all four limbs has been reported in sheep with lesions of polyomyelomalacia similar to those that occur in pigs with selenium toxicity. The lack of LM and dysfunction in the pelvic limbs makes this diagnosis very unlikely in this ewe. Listeriosis is very common in ruminants but is a disease that regularly affects the caudal brainstem, and clinical signs of spinal cord dysfunction are rare or unrecognized because of the severity of the pontomedullary lesions. We have never observed clinical signs of focal spinal cord dysfunction in a ruminant with an autopsy diagnosis of listeriosis, but myelitis caused by this bacterium has been reported from Australia. Unilateral facial paralysis and vestibular system dysfunction are common clinical signs seen with pontomedullary listeriosis. Lumbosacral CSF contained 560 mg/dl of protein, normal, 40, 893 RBCs mm3, and 569 WBCs mm3, normal, 5, with 87% macrophages, 13% lymphocytes, and 5% neutrophils. These findings are most compatible with a severe case of listeriosis with extensive meningeal inflammation. Although mild cases of listeriosis may respond to antibiotic therapy, the owner elected to have this ewe euthanized. The diagnosis of listeriosis was confirmed with moderate lesions in the pons and medulla and remarkably extensive necrotizing lesions in the cervical intumescence centered in gray matter, but the inflammation also extended into the nerve roots, which is very unusual for listeriosis. The bacterium Listeria monocytogenes was immunocytochemically identified in macrophages in the lesion. See Video 11-34 of a 4-month-old castrated male mixed breed lamb that became unable to stand after 3 days of progressive difficulty with walking. Note the severe non-ambulatory tetraparesis with increased muscle tone in the pelvic limbs and decreased muscle tone in the thoracic limbs. The withdrawal reflexes and nociception were both reduced in the thoracic limbs. The anatomic diagnosis was a focal lesion between spinal cord segments C6 and C2. The most common presumptive clinical diagnosis is discus spondylitis or a vertebral canal abscess. Although experimental studies support the possibility of P. tenuis myosis at this age, the young age for a natural infection make this diagnosis less likely. Clinical neurologic signs of copper deficiency are observed at this age, but such a rapid onset of tetraparesis and the disparity in the quality of the paresis between the pelvic and thoracic limbs would not be expected. Radiographs, see video, revealed discus spondylitis at the C5, C6 articulation. The lamb was euthanized, and this diagnosis was confirmed at autopsy. Video 11-35 shows a 2-month-old female mixed breed lamb that was vaccinated and had her tail docked when she was 2 weeks of age along with a large group of other similar aged lambs. The following day, it was noticed that this lamb was unable to stand using her pelvic limbs. 2 other lambs had difficulty using their pelvic limbs but recovered in a few days. This lamb remained unchanged over the next 6 weeks before this examination. Note the severe spastic paraparesis and the difficulty that this lamb has supporting her trunk when held by the stump of her tail, but note also her normal thoracic limb function. Also note the suggestion of a mild elevation of her cranial thoracic vertebral spinous processes. Your anatomic diagnosis should be a focal cranial thoracic or diffuse lesion in the spinal cord between the T3 and L3 segments, probably involving the more cranial components of this anatomic diagnosis. The sudden onset without progression of clinical signs for 6 weeks suggests a spinal cord injury or vascular compromise. We have not observed FCEM in ruminants, and the recent vigorous handling of these lambs just before the observation of their clinical signs makes an injury the most presumptive clinical diagnosis. Radiographs, see video, showed a healed compression fracture of the third thoracic vertebra with a mild degree of kyphosis at the fracture site. The lamb was euthanized, and this diagnosis was confirmed at autopsy. The bones of foals and young farm animals may be at risk for fracture because of deficient ossification. Case example 11-11 signalment. 2-week-old female mixed breed pig chief complaint. Abnormal use of the pelvic limbs history. This pig was found in her pen unable to stand on her pelvic limbs. She was not observed well enough to know whether the onset was sudden with no progression of the clinical signs or if this disorder was progressive. She was normal at birth. Examination. See Video 11-36. Note the elevation of the vertebral column at the thoracolumbar junction. Anatomic diagnosis. Focal or diffuse spinal cord lesion between the T3 and L3 segments according to the small animal grading system for function. This condition is a severe grade 3 spastic paraparesis and ataxia. Differential diagnosis. Vertebral malformation with kyphosis. Vertebral fracture with displacement. Vertebral abscess with pathologic fracture and displacement. FCEM. All 4 of these clinical diagnoses occur in pigs and could cause these clinical signs of spinal cord disease. Imaging is necessary to differentiate them. Radiography showed a vertebral malformation with kyphosis at the T1-3, L1 articulation and associated narrowing of the vertebral canal. FCEM occurs in young growing pigs and is often associated with experiences that make trauma a risk, as occurs during the transportation of large numbers of pigs. The age of these pigs makes the vertebral growth plates a consideration for the source of these emboli. Figures 11-62 through 11-66. This disorder was described in detail in case example 10-1. Nutritional and toxic forms of myelopathy occur in pigs. These forms cause progressive clinical signs and would be a consideration in this pig in this case example in which the history is unclear. However, these circumstances would not cause the vertebral deformity that was observed in this pig. Copper deficiency causes a rapidly progressive paraparesis and pelvic limb ataxia in 3.5 to 6-month-old pigs that can progress to paraplegia. This condition is similar to the disorder that occurs in lambs and kids at that age that is related to copper deficiency. In all of these species, this disorder causes a degeneration of axons and secondary demyelination. Neuronal cell body degeneration also occurs in widely dispersed areas of the nervous system. Organic arsenicals are sometimes added to the ration of pigs as growth stimulants and to prevent dysentery. Overdose of arsenic acid initially causes a progressive spastic paraparesis and pelvic limb ataxia, 50, which progresses to involve the thoracic limbs and is followed by recumbency. At autopsy, diffuse degeneration of axons and myelin is noted. Video 11-37 shows a 10-day-old female mixed-breed pig found in its pen with dysfunction of her pelvic limbs. The nature of the onset and the course of the clinical signs are unknown. Study the video. Your anatomic diagnosis should be a focal or diffuse spinal cord lesion between the T3 and L3 segments. The differential diagnosis includes vertebral malformation, vertebral column and spinal cord injury, vertebral column discus spondylitis or vertebral canal abscess, FCEM, or nutritional myelopathy. Nutritional myelopathy is unlikely at this age with such severe clinical signs in the pelvic limbs. Most vertebral malformations that cause enough kyphosis to compress the spinal cord are usually visible or palpable, as in this case example 11-11. Imaging is necessary to differentiate the other diseases. Radiography showed a compression fracture of the L1 vertebra. Video 11-38 shows a 1-month-old female mixed-breed pig with a history of not using the pelvic limbs for 10 days. Study the video, and note the reluctance to use the pelvic limbs. Therefore, you cannot determine if she is unable to use them as a result of a neurologic disorder or if she is just unwilling to use them because of an orthopedic disorder that causes discomfort. Note that she walks almost entirely on her thoracic limbs by contracting her thoracolumbar epaxial muscles to extend her vertebral column so that the pelvic limbs do not bear any weight. When she is held up, you can see the marked enlargement of both stifles, and the radiographs show the extensive lysis associated with a bilateral stifle infection. Video 11-39 shows a 10-week-old female mixed-breed pig that was noted as having difficulty using her pelvic limbs and exhibiting an unusual action with the right pelvic limb. This problem was initially thought to be a form of myoclonus caused by a spinal cord lesion before we received the pig for examination. Study the video. In our opinion, her neurologic examination was normal. The clinical signs were caused by a lesion affecting the right stifle, and the pig was reluctant to bear weight on that limb. When she leaned to the left to avoid bearing weight on the right pelvic limb, the digits came off the floor, and all the repetitive movements were her attempts to reach the floor with the right pelvic limb digits. When I placed my hand against the plantar surface of the digits, the action stopped. The radiographs show the severe infection involving the right stifle and adjacent tissues. This pig was euthanized, and an autopsy showed a suppurative lesion involving the right stifle. No microscopic lesions were found in the CNS or nerves in the right pelvic limb.